then if any questions, otherwise we will wind up the sessions, okay? Thank you.
Next, I invite Dr. Shajidha K S MOB to hand over the memento to Dr. Rajesh KM. I request Dr. G.G. Palokaran, Professor and HOD, MOSC, Kolancheri, to present the memento to Dr. Shajidha K S MOB. POCT is an integral part of diagnosis in present-day clinical practice. It is often being used by non-laboratory staff, and the results are used for immediate clinical decisions. The errors will have serious consequences. Hence comes the importance of quality assurance, and it is a challenge in POCT use. Our next session is about the quality challenges in quality assurance and the scope of including POCT in NABL. I invite Dr. Reshma Regu, Consultant Biochemist and Lab Director, Aster Clinical Labs, Aster MedCity, Kochi, to deliver the session. Dr. Reshma Regu has 10 years of expertise in clinical biochemistry lab management and medical teaching. After completing MBBS from Amala Institute of Medical Sciences, Thrissur, in 2009, she did MD Biochemistry from St. John's National Academy of Health Sciences, Bangalore, Karnataka. She did MBA in Hospital and Health System Management from BITS Pilani in 2022. She was a Certified Internal Auditor and Quality Management System, ISO 15189, 2022 from Bangalore, FQI, Bangalore. She received certificates in patient safety at CAHO, risk management in laboratories, CAHO program on implementation of NABH standards for hospitals. She has been part of clinical audit conducted by NABH, also research methodology from St. John's Medical College Research Society, Bangalore. She has done postgraduate diploma in clinical research from Catalyst Clinical Services. She was awarded Site Star of the Year 2018 award for Site Care Hospitals Private Limited, Bangalore. She received the Best Poster Presentation Award for the paper title, A Study on Vitamin D Status Among Healthy Women Attending a Tertiary Care Hospital in Golden Asopicon 2014, held at Jipmer, Pondicherry. She presented the Dr. Jagdish Ignin Memorial Award paper presentation at the second state level Ambicon 2014, held at Kolar. I welcome Dr. Reshma Regu to present the session. I invite Dr. Jesse S.J., Professor and HOD, Government TD Medical College, Alapura, to chair the session. Dr. Jessie S.J. completed her MBBS from TD Medical College, Alapura in 1996 and MD in 2002 from Government Medical College, Trivandrum. She has more than 25 years of teaching experience and has numerous research publications in both national and international journals. We are delighted to have her on the dais as the chairperson for the session. Thank you, ma'am.
Good morning, everyone. It's actually a pleasure to be here among the esteemed colleagues, my beloved teachers, and also experts in laboratory medicine. I take this opportunity to thank the organizing committee for inviting me here to speak on the most important topic of today, which is the point of care testing in the diagnostic industry. So I'm here to share my thoughts about quality assurance in POCT and also a little bit of challenges and how to take POCT forward when it comes to accreditation practices. So as all of us are aware, the advancements in diagnostic technology and a growing emphasis in the patient-centered care and also increasing decentralization of healthcare services all have driven the rapid expansion of POCT. Even the IFCC Committee for POCT has recommended POCT for outside hospital setting, which can be performed by healthcare professional even without a formal training. So today POCT is no longer just a convenience for us, it is actually a necessity for all the home-based and hospital-based care. Actually, this is the day of home-based care. Post-COVID, the home-based care has really taken into picture. So with this rapid expansion of POCT across the laboratories to the EDs and ICUs and OPDs and even to the home care, this has actually bridged the diagnostic from central lab to the patient's bedside. So this paradigm shift has actually given us a lot of advantages, but at the same time this comes with a lot of complexity and risk for patient care. So as Dr. Rajesh rightly mentioned in the previous presentation, POCT comes with a lot of challenges, though we have a lot of advantages added to it. So right from staff training to the standardization, QC, data management, device storage and reagent preservation, and also the management oversight, all this actually add to the POCT challenges. So when we talk about POCT in a quality assurance perspective or an accreditation perspective also, we have to go through all these challenges and we have to overcome them. So when you really talk about quality assurance challenges, so what we really need, come across as a lab personnel, as an in charge of the POCT committees, basically since we all the hospitals and the clinicians and even all the POCT operators take POCT very lightly. Even if it is a simple glucometer, they think like there is no risk associated with it. Most of the times we don't have a SOP, no service agreements are in place where the responsibilities of each and every person is mentioned in it. We don't have critical alert policies. We don't have like outliers, like when they may be doing QC. First of all, most of the places don't even have a quality control practice for POCT at times because thinking about the cost and difficulty in management and so on. So these all actually fail to take actions for outliers, and also documentation in terms of recording the quality control data is also very poor. So all this will actually add on to a risk for the patient care. Knowingly or unknowingly, we are adding risk to the patient care. So how can we overcome these challenges? So basically, to ensure quality, accuracy, and also regulatory compliance in terms of accreditation practices, it is highly important to mitigate the risk. We have to identify and as well as mitigate the risk. And then only we can uphold the integrity of patient care across diverse clinical settings. And for this, you require a structured multidisciplinary approach. So basically, three important things are required. We need the proper governance in terms of management responsibility and other requirements. We need a proper training program and also a quality assurance protocol. So all this is actually a multidisciplinary teamwork. So together we can actually overcome these challenges, whatever I mentioned in the previous slide. So what are the key factors for any lab test or be it a POCT? The key factors to take the quality forward is nothing but the hospital leadership support. Without management support, we cannot achieve quality. Next important thing will be a multidisciplinary approach wherein all the stakeholders come and participate in the discussions and also in the policy making. And then we have to have a robust data management system because all this QC recordings and taking the QC forward requires proper recording of the data. And we also need standardized protocols to keep everything in place. Without management responsibility, POCT cannot be taken forward because loss of cost involvement is definitely there when you have to have a proper quality assurance practice in place. So management should take the ultimate responsibility of POCT quality, as well as service agreements must be in place so that we can communicate the same responsibilities and delegate the duties to the clinical, operational, and also the financial domains. Qualified lab personnel should be appointed to oversee the quality assurance practices. Mainly POCT director should be the, most of the places the lab director takes the responsibility of POCT director as well, and under the lab director should have a POCT coordinator, and the quality manager of the lab usually takes the dual responsibility of as a POCT coordinator. And a multidisciplinary committee is also highly important, which can actually contribute to the continuous quality improvement of the POCT program. And last but not the least, we should also take in the accreditation bodies or other international societies' recommendations based on the scope and the complexity of device we are actually using. So, as I already mentioned, the multidisciplinary team, the POCT committee is highly important for any organization handling POCTs. Be it you are going in for accreditation or not, a POCT committee should be in place so that we can have proper quality reporting in POCT devices. So, any head of the institution can chair the committee with the help of POCT director, and also we have to incorporate all the stakeholders, the clinical super users, basically the doctors from EDs, ICUs, and medical and surgical specialties, along with the nursing team, because they are the core operators of the POCT program. So with the help of nursing management, nursing educators, and the core nursing team, we have to, we can include them so that we can improve the POCT practices, along with lab, IT, and biomedical and supply chain support. So the POCT committee actually handles a lot of core responsibilities when it comes to quality assurance practices of POCT. So right from the device selection to the technical troubleshooting and accreditation, everything goes through the POCT committee. So without a good training program, we cannot really have a quality assurance practice in place. So as the previous speaker rightly pointed out, training is the biggest challenge when it comes to POCT, because all of us are aware the POCT is usually operated by the technician who is actually not trained in lab practices. So the training requirements right from the pre-analytical, analytical, post-analytical, all the phases of POCT testing also should be included when it comes to POCT training. And ongoing training and the competence assessment of the staff is again an important challenge, because when it comes to a hospital like a 500 bedded multi-specialty hospital or something like that, we have maybe thousands of nursing staff who is handling the POCT. So there should be ongoing training practice along with competence assessment evaluation, so that each operator is knowledgeable about the POCT, how to operate, how to perform QC, how to interpret the same, and so on. So basically we need to have recertification practices. Maybe you can make it more interesting with a quiz or a hands-on training workshop or something like that, depending upon the complexity of the device. So, but the key important factor here is ongoing training should be given with a competence assessment for all staff, and the same needs to be documented. So as I already mentioned, a lot of challenges comes with this training when you go in for accreditation. We don't have enough documentation, because thinking glucometer, it's a simple device. They don't actually train the staff. So, and all the staff are from diverse educational background, and most of the time there is poor coordination between the POCT team, the lab team, and the nursing team. So with all this, we can actually improve the POCT program and the training associated with it with the help of POCT committee as well as the nursing team. So peer-to-peer training is actually ideal to take this forward. And the training, as I already mentioned, it should cover all the areas of POCT practices. Now, moving on to the importance of quality assurance, why we need quality assurance practices in POCT. So, just like our laboratory investigations, POCT is also highly prone for errors from all three phases of the workflow. So commonest source of error, unlike our lab test, the common source of error for POCT is actually in the analytical phase, not in the pre-analytical phase. But the problem here is we cannot really translate we all have laboratory QC program, IQC protocol, eco programs and so on. But we cannot really easily translate this particular IQC protocol of the lab to POCT. But again, the importance of POCT QC protocols cannot be neglected as well. So here the need of the hour is actually an effective quality assurance practices which actually encompass all aspects of POCT testing, right from the pre-analytical to the post-analytical phase. So the quality assurance program is basically required to manage the error, to identify risk, and also to have a reliable POCT result which can be provided for the patient care. So again, when it comes to the management side, POCT is actually a device which is actually placed near the bedside just to facilitate the patient testing and reduce the turnaround time of investigations. But when it comes to operational challenge, the cost cannot be an add-on factor. So when we develop and implement a QA program, we have to really keep this in mind. We cannot excessively contribute to the operation cost, and also we cannot add the complexity of maintaining the equipment. So just like lab program, we should have IQC protocols, we should have EQA, and we can have device verification and reagent lot validation protocols and method comparison protocols. So just like any lab quality assurance program, we should cover all this area in POCT as well. So how can we assure quality? So when it comes to POCT, most of the times what happens is the management or the user decides which POCT the particular organization or particular department wants. Most of the times what we come across as a lab personnel is like the management will tell us, okay, for this particular department the turnaround time is increasing. For example, HS tropi. Cardiac department also requires an HS tropi or BNP. They would have just had this thought based on the turnaround time, and maybe to improve the TAT in the cardiology department, they just thought of giving a POCT to cardiology, but they wouldn't have thought how to select this, or they don't have an ability to monitor the IQC, or they don't have proper training or documentation for this. So if this POCT is under the lab, which is like the lab is overseeing the POCT practices, then it is actually having meaning to the, actually adding meaning to the clinical practice. But otherwise what happens is, they don't have proper practices in place. The nurses will be just taking the sample, running it and giving the report. But whether the analyzer or the strip or whatever be the test methodology is working fine or not, nobody knows. And the cardiologist or the clinician will be really depending upon this result to take medical actions as well. So without internal quality control, we cannot carry on POCT testing, as we all know. So how to take the, how to formulate a proper IQC protocol is the question which we will be answering now. So IQC protocol should actually be defined based on the device complexity and also risk management practices. So each organization should identify the risk based on their experiences and concerns they come across, and then they have to identify platforms and identify protocols to mitigate those risks. So again, depending upon the device complexity and risk management, we have to identify IQC protocols. But again, IQC should be performed at regular intervals, preferably daily or at a minimum when the patient testing is occurring. And it's not the lab who is going to perform the quality control, it is just the users. All the operators should be running the quality control and taking the appropriate corrective action. The role for lab is only to oversee the QC performance, not to run the program. The QC material of choice will be supplied either with the kit as a manufacturer QC or a third-party control, just like in how in lab we are doing it. And the important characteristics of QC will be, as I already pointed out, this is actually used by the QCs are run by non-lab personnel. So you have to have the principles which are very easy to use, no reconstitution or dilution, no thawing is required, and this should cover clinically relevant ranges as well. And what is the conduct of QC like? Ideally for POCT, the QC is recommended when there is a new lot or new delivery of consumables arrive. And whenever there is a discrepant patient result, substantial maintenance procedures are required for the device, or if the device has suffered a physical insult. For example, if the device is stored in a high temperature room, or there is a fall which has happened to the device or something of that sort. And about the frequency of testing, it is analyzer dependent, depending on the device complexity. These days, most of our POCT devices like ABGs and other sorts are coming with inbuilt QC check systems. So if an inbuilt system is there, we can reduce the frequency of doing the internal quality control. And also we need to take in consideration the risk associated with release of incorrect results, and also the number of users who is going to use the QC. And what are the role of manufacturers here? So when a POCT is being designed, they should take into consideration it is being done by non-lab personnel who don't have formal laboratory training. So the device should be simple. When we select also, it should be simple, easy to use for the operator, and it should be designed to prevent user errors. So it's always to go in with a device which has inbuilt QC, like auto QC or electronic QC and of that sort. And most of the analyzers these days come with electronic QC, which is actually a middleware or a software platform which actually automates your quality control in POCT. This actually will help you to reduce the errors associated with the QC processing by the operator. This will trigger the IQC samples at a user-defined interval even without the operator prompt. And this is actually a built-in QC protocol, so statistical rules are already applied to it, which will identify your outlier, your shift and trend in IQC can also be pointed out. This can also interfere, interface with your data management system of the hospital, and this can give you real-time dashboards, trend analysis and audit trails. What we actually lack in terms of accreditation practices is this real-time dashboards, trend analysis and audit trails when it comes to the POCT. And these days, new models have come with built-in IQC like intelligent quality management system protocols. This actually automatically runs for every patient sample. This will help us to prevent the release of invalid results before the operator even sees them. So most of the times, the POCT operator would have run the QC, but they wouldn't have identified the QC is actually out, or there is a problem in the equipment. So this particular system, if it is there inbuilt, this will actually prevent your system from releasing any patient results. So inbuilt IQC, actually one important point about this is not going to assess the normal patient sampling procedure or your user performance, but what this is going to do is to just prevent your patient sample from being processed. So depending upon the complexity, we have to devise our IQC protocol. So these are the important protocols which we can actually practice in our hospitals or laboratories wherever the QC requirements are there for POCT. So whenever it comes to low complexity ones, just like our urine strips, our rapid pregnancy test or rapid antigen assays in the microbiology, serology area, or a fecal occult blood, all this actually comes with inbuilt control which provides additional assurance to us. Apart from that, we can also process positive and negative quality control for each lot. And in addition to this, monthly internal quality control should be done for representative kits from each location. This is actually done to identify whether the storage protocol is in place or not. Now it comes to the little more complex ones, which is the quantitative strip-based methods like our glucometers, INR strips and all that. So in this case, this is actually a high volume parameter. Most of the times the nurses will be doing this particular test. So what we need to do is we have to incorporate more quality control practices to this, because this is more error prone as well, because there are no other QC self checks in place. So multiple levels of manufacturer recommended QCs can be run daily. Minimum practice should be to do a single level of QC, if not 2 levels. So since we are getting a lot of QC data points here, we can actually plot these points on an LJ chart. But again, when it comes to practice, it's highly difficult because these data is being recorded by the nursing team and they may not have a proper recording pattern in most of the places. So if you have a good data management system, this can be overcome. And Apart from this, we have to also have a manufacturer recommended quality control which is run at least monthly on every instrument at a site. So most of the times what we do in our hospital chains is like we call the glucometer manufacturer team to do this monthly QC, and rest of the daily QC will be run by our nursing staff, and the QC results are actually overseen by the POCT team from the laboratory. Now coming to the single-use cartridge, which is a little more highly complex ones like HbA1c or about iStat and all those. So in those cases, we have a functionality of electronic QC which is inbuilt in it. And along with that, we have to do liquid QC as well. So when you have the electronic QC, the system checks are actually being done, but if you don't have this electronic QC which is available in the platform, we have to also add liquid QCs. So 2 levels of IQC to be done daily if you don't have an electronic QC, or else 2 levels of IQC can be done monthly. Now coming to highly complex multi-analyte devices like a multi-use cartridge, basically our blood gas analyzers, coagulation analyzers, or multiplex immunoassay platforms. In those cases, we have to have a daily multi-level QC which is actually recommended by the manufacturer or a third-party control, apart from the automated QC at predefined intervals. So now how can we innovate in documenting the QC data? Most of the times what happens is we will, the nursing staff or the POCT operator will have a register wherein they will be just documented the QC result with the date or the result value along with the signature or whatever. But what happens is like most of the times they are not even realizing whether the QC is actually in or out, whether it is acceptable or not acceptable. So a protocol can be devised if it is feasible, just like here actually it represents the green color represents the QCs which are actually in, that is between your plus and, for all quantitative assays, like even for glucometers, we can actually have this in place because we have the reference ranges with us provided by the manufacturer, or we can devise our own mean and standard deviation. So with this we can actually have a reference range which is developed by the lab. So with this we can implement a color coding kind of a pattern so that the for operator it is easy to understand. So if we give them a chart like this with a green color coding for a result which is acceptable, which is between plus or minus 2 standard deviation from the mean, and if the color is like amber, it is between plus or minus 2 standard to 3 standard deviation, and if it is beyond 3 ST, it is definitely, the QC is definitely not acceptable. So that actually alerts the operator to call in for the POCT team or a biomedical engineer to help them out so that they don't even process the samples. So these kind of practices can be devised which will actually help the POCT operators to understand whether the QC is in or out. So as I already mentioned, we can develop a QC acceptance criteria just like how we develop in lab for POCTs as well. So when the QCs are out of reference ranges, we can actually stop processing the patient sample, inform the POCT team, and most of the times these POCT devices are closed systems. So we will have to call in the manufacturer's representative or the application team for troubleshooting. And always keep in mind to check the storage of the device and the strips or the reagents, how the nursing team have, or the supply chain have stored these reagents. So whenever there is a QC outlier without troubleshooting, we should not carry out testing. But again, implementation at ground level of this QC and QC acceptance criteria and troubleshooting is quite challenging. Repeated training and repeated telling to the nursing team is only going to work out in this way. So most of the places have these epochs in the ED or triage in the cardiology ward or glucometers, so everywhere we have. So implementation is quite challenging when it comes to IQC protocols. Now moving on to ECO and PT program, the NABL, NABH and JCA, most of the accreditation programs actually recommend the use of ECO program, participation in ECO program. But again, the challenge is the cost and the availability of such a program for POCT practices. So again, the Ideal recommendation is to participate in a quarterly or a biannual EQA program depending upon the device complexity. But unfortunately, most of us cannot participate due to the cost challenges and also the availability issues. So at least a split sample testing should be done if a formal EQA program participation is not practical in our organization. So what we can do is, we can consider central lab testing as the standard reference method, and we can analyze the same patient specimen which is analyzed concurrently by POCT on the central lab method. Again, when it comes to the result, a lot of bias can be seen, especially in terms of glucose. We actually in Aster, what we do is, we run daily QC for glucometer. At least minimum one level of QC is being run for all the glucometers which are in the circulation. But and the EQA, again, EQA participation is not available due to cost constraints. So what we have implemented is a split sample testing. This is even recommended by JCI to us. So split sample testing is being carried out monthly. 2 times we are doing, like first 2 weeks and then the next 2 weeks. After next 2 weeks we are again doing. So minimum 5 to 10 split samples are being done per instrument per month. But a lot of variations we come across in terms of results between glucometer and the central lab testing. So those aspects are little difficult to address, but again it's better than not having an EQA program. So we are again continuing with the glucometer split sample testing. And now we also need to keep in mind, we have to also include both normal and abnormal samples when it comes to split sample testing. Method comparison between instruments like your central lab instrument and also the POCT is a must, and at least twice a year we have to do with minimum 3 specimens, that is low, medium and high concentration should be incorporated into. And just like how we do in lab, we have to also practice reagent lot evaluation. So for all new shipments or new lot numbers, we have to do reagent lot validation, and this can be practiced by for quantitative tests you can use quality control material maybe 3 times for each QC level, and apart from that we have to also have sample comparison. 5 patient sample comparison can also be practiced. For qualitative, a negative and a positive control can be used. And documentation is the key important part of the quality assurance practices. So we need to have a robust documentation system in place. Repeatedly we have to follow up, the lab team have to follow up with the clinical users so that they are more aware, they are more alert on how to document and how to implement the documentation part. So the POCT director need to approve and periodically review the specified policies which are again formulated by the POCT committee. So recording of QC data should be really made simple and reliable, and plotting of QC results can be done on LJ chart with the operator's name and so on, and appropriate corrective actions to be taken for outliers also need to be documented. And when it comes to ISO 15189-2022, risk is the most important part which needs to be addressed by us. So just like how we do risk management protocols in the laboratory, we need to have the same practices to be done for POCT as well. So in the pre-analytical, analytical and post-analytical phase, we have to implement risk management strategies for identification, mitigation and so on. Key performance indicators can also be put in place so that we know where we stand inside the organizations. So in order to track how the POCT is actually performing, we can have key performance indicators in place in all these areas so that we can identify areas of improvement. After all, it is a continuous process improvement which quality assurance is required for. So this actually facilitates the identification of systemic issues so that you can develop root cause analysis and corrective action plans, and new strategies can be implemented to improve the quality of practices. So we need to monitor the key performance indicators or the quality indicators monthly, and this can be discussed in the POCT committee along with the POCT team. So at least monthly the POCT committee need to get along and discuss all these non-compliances and also take some corrective actions for the NCs identified. So the biggest risk to quality in POCT is related to the clinical users not following policies and procedures. So though we have a lot of quality assessment tools like risk management, clinical audit, IQC or EQA performance monitoring, training and rest all other statistics which are in place, but the biggest challenge comes with people not really following the SOPs. So what can we do for that? For that, what we can do is we can actually have focused audit. Wherever possible, the POCT coordinator or some designated person can go around and have a look how the POCTs are being maintained, how the testings are being done at the ground level, and also the documentation part. And without data management, we cannot progress on quality assurance. So interfacing, connectivity and data management are highly essential part of POCT quality assurance program. So this actually ensures that the capture and documentation of patient as well as the control results are done properly without much manual errors. And this also helps us in auditing the internal quality control and also the patient results. So as I mentioned, focused audit should be put in practice so that the audits are basically conducted, minimum 1 or 2 audits per year should be conducted within an organization so that we know where we stand in the POCT practices. So we can cover, and these are the common areas which we can do audit on, like in little bit about training part, usual errors, the documentation, critical result complaints, labeling and storage, how they are placing these reagents, and also the QC performance. All these areas can be really looked into, and wherever improvement is can be made, we can develop strategies to improve. Now the accreditation journey. So if we have a proper quality assurance practice in place in your organization, the accreditation journey will be smooth. Otherwise, most of the places, most of the organizations, be it hospitals or laboratories, what they have done is they have removed the POCT. They are not showing to NABL or accreditation bodies that they have POCT in place. So it's quite challenging to include POCT devices in the NABL scope of accreditation, that is for sure. But the main hurdle what all the labs face is in terms of documentation and the quality control practices what they follow. So the new ISO standard, the ISO 15189-2022 version, it actually gives a lot of importance for POCT. That particular decentralization which has happened in the industry has same affected in the ISO 15189 document as well. So what has happened is all the POCT should be documented as per the new guideline of NABL. So this requires documentation of all POCT locations and all the services. This actually mandates that POCT sites provide suitable premises, just like how the NABL gives guideline for the lab practices should be, how the lab temperature, this and that should be. Same way they give guidelines for POCT as well. And this also defines acceptance testing protocols to be devised for POCT reagents and devices, ensuring no patient results are released before verification. And also we need to introduce formal service agreements between the lab and the clinical units in order to outline responsibilities, roles and other commercial terms. And we also have to have regular risk assessment practices in place to emphasize error prevention and patient safety. And lastly, it is actually a summary of governance, quality assurance, training and competency for POCT. NABL actually gives you an outline of how to carry out this POCT practices, but rest of it is actually institutional, and the POCT committee can decide what level of IQC practice you should place in your organization. So some tips will be for POCT NABL implementation. In Aster, what we have done is we have all our POCTs, including our glucometers, our coagulation devices, ABGs in the critical care areas. All the POCT devices are under NABL, NABH and JC accreditation program. So we have a beautiful, robust POCT committee in place, which actually decides and designs the POCT program. And we have a POCT coordinator who is headed by the POCT chief, And we can actually have best practices if you really monitor right from the device selection to the implementation of all the policies. So if you map the existing, what most of us will have little or at least some of the whatever practices I have mentioned today. So what you can do is, in order to convert to your 2022 version, you can actually map your existing POCT practices with the new ISO clauses using a gap analysis metrics. And along with that, you can also give a responsibility. If not appoint a new personnel, you can give an additional responsibility to your quality manager or whoever is in charge of your lab quality to design and oversee the POCT program. And you can also have a POCT committee in place with the help of clinicians, management and other stakeholders. We can develop quality assurance and competency evaluation program for POCT, and we should also create, because these are the, we should not forget about the training part, because the users, the operators are basically non-lab professionals. So you can give them like a flow chart or checklist or a mnemonic to understand what this POCT QC is all about. And we can also make SOPs to illustrate the end-to-end POCT quality management system. And also we need to leverage digital dashboards to track the POCT KPIs and risk. Also we can integrate with hospital networks for real-time data analysis. So basically when it comes to POCT, it is the team who is going to support the POCT practices and guide the quality assurance journey and finally lead you to the NABL or another international accreditation. So good quality assurance is going to bridge the gap in POCT. So basically POCT is a good innovation. It has really improved your patient care, it has improved the TAT, but the problem here is, let us just not deploy POCT, let's decode the care through quality with the best practices what we can implement based on your organization policies and also the operational constraints. And let's not just transform diagnostic, let's save lives. That's all, thank you.
The session is open for discussion and questions.
Yes, ma'am.
Thank you very much. It was a very, very insightful talk and very helpful also. So I had a small query in this. You were talking about using split sampling in case of equa not available.
Yeah.
So split sampling, what I understood is like we can run the same sample on the POC and run it on our lab machine also. Now can this only be taken as a method comparison, because you spoke about method comparison?
Actually, we can address both with the split sample testing. Because method comparison you can do only once in 6 months. You can document it. But when it comes to split sample testing, it is actually equivalent to your equa program, because most of us don't even have a robust equa program in place for POCT. So what the accreditation bodies, the assessors also recommend is, at least that is a bare minimum what we can do for POCT is a split sample testing program in place.
So both can be used interchangeably?
Yes, yes ma'am.
And one more query I had, like you also made a mention of it, that the challenge here is method comparison. Like the values that you get in the lab is not the values that you get, especially with glucometers and all that. The values are different. So how do you actually do the comparison and how do you actually accept them is what I wanted to know.
Yeah, that is what. Actually, it is there are no standard guidelines which really say this much bias is acceptable between a POCT and the lab methodology. So basically what we do is the 10% bias is really acceptable, like that we have kept a guideline. But again, when it comes to the reference for that particular criteria, there is no solid evidence for that. So probably in the upcoming days there will be more guidelines which is coming from NABL and CAP and all that, because no accreditation body gives a robust guideline how to implement this quality control practices for POCT. It is still like an ongoing one.
Okay. Thank you so much.
Very nice talk, doctor. Actually, I just want to add one more thing. As you told the thing regarding the no accreditation body has given some kind of bias on the limits regarding the glucometer stuff actually. It is right only, but I think meanwhile, when till the time when they are going to give something like that, recently 2025 AD has released actually regarding the glucometer stuff. They have given some references also. For example, if the value is, the lab value is something like 75 milligram per deciliter, if it is below that or above that, something like that, plus or minus 50 milligram per deciliter or 15%. Okay, so 3 guidelines they have given based on ADA. But you're right, they have never, the NABL and the accreditation committee never asked.
They have not given any standard guidelines so far.
They haven't given that. But in certain time, actually, unless they have given such a, they haven't given such a thing, we make an use of that things also for a reliability stuff too.
Yeah, that is what. Okay. So what we can actually devise for POCT is, we can actually go in for the international societies guidelines most of the times. That can be put into practice.
Yes, that's what I have. Yeah. So that reference is available in online also in ADA site. Okay, so I think everybody can take it also. Okay.
Thank you.
Any more questions? It was indeed a very insightful presentation, very lively, very informative. I invite Dr. Jesse S.J., Professor and HOD, TD Medical College, Alapura, to present the memento to Dr. Reshma Regu.
Thank you, Dr. Reshma, for the precise, concise, and I think she have covered most of the areas. We know that maintenance and management of POCT requires inventory control management, documentation, and quality assurance is the most important thing. And discuss in detail the challenges in quality assurance, mainly the IQC programs, and discuss in detail the IQC programs that can be run under various devices, and also based on the complexities how the IQC programs have to be run, and also discuss the IQA that have to be run, the proficiency testing. And I learned that the proficiency testing nowadays, since it is being based on the cost, they are moving on to the split sampling technique and method comparison. One doubt I want, is there any CLSA criteria for this POCT?
Yes, ma'am. There is a document which is available under CLSI.
Okay.
But again, when it comes to the quality assurance practices, some of them doesn't give a robust set criteria. We can use sigma metrics and all other things. We can implement.
That can be included.
That can be implemented.
Okay, sigma metrics can be included in here also.
Can be implemented.
Okay. Thank you.
Thank you, ma'am. Yes, ma'am. Ma'am, actually, Randox has some of the POCT, for POCT, madam. This one, ma'am? Before that, okay. The next one? Okay, ma'am. Sure.
I request Dr. Jesse S.J. to present memento to our speaker, Dr. Reshma Regu. I request Dr. Shibu T.S., Professor and HOD Biochemistry, GMC Manjeri, to present memento to Dr. Jesse. Thank you, sir. Thank you, ma'am. I'm confident that these deliberations and exchanges will inspire us to strengthen our POCT practices, foster collaboration between clinicians and lab professionals, and ultimately enhance patient care outcomes. Now we proceed to the inaugural session. I request Dr. Gilsa E.S., Professor and HOD Biochemistry, to deliver the welcome speech. I beg your pardon. We take some time to arrange the dais. I also ask our student to get ready for the prayer song. So it's time for a prayer song. Okay. I invite Dr. Anil Kumar P., Vice Principal and Principal in Charge, GMC Erakulam, on the dais. Sir, please. I invite Dr. Binu Erikal, Professor and HOD of Community Medicine and Nodal Officer of SBMR GMC Erakulam Unit, on the dais. I invite Dr. Indira C.K., Professor and HOD Anatomy, GMC Erakulam, on the dais. I invite Dr. Deepa Augustine, Coordinator of MEU, GMC Erakulam, on the dais. Let us stand for the prayer song.
ചൈതന്യമേ നിത്യ ചൈതന്യമേ കൈകൾ കൂപ്പുന്നു സംപൂജ്യ സന്നിധിയിൽ പല ജാതി വർണ്ണങ്ങൾ എല്ലാം മറന്നേക മനസാൽ നമിക്കുന്നു ജ്ഞാനാദരം ചൈതന്യമേ നിത്യ ചൈതന്യമേ കൈകൾ കൂപ്പുന്നു സംപൂജ്യ സന്നിധിയിൽ
Now I invite Dr. Gilsa E.S., Professor and HOD Biochemistry, GMC Erakulam, to deliver the welcome speech.
Very good morning to all the dignitaries on and off the dais, my teachers, seniors, colleagues, friends, and other esteemed delegates. It gives me immense pleasure to welcome you all to the CME on POCT. In the ever-evolving landscape of healthcare, point-of-care testing has emerged as a transformative tool, bringing diagnostics closer to the patient, enabling faster decision-making and ultimately improving the clinical outcomes. This CME has been designed as a platform for clinicians and laboratory professionals to explore the opportunities, challenges and advancements in POCT while ensuring its effective implementation in alignment with clinical protocols and regulatory standards. On behalf of Department of Biochemistry, Government Medical College, Ernakulam, I extend a warm welcome to our esteemed patrons, Dr. Anil Kumar, our Principal in Charge and Vice Principal, who despite his demanding schedule graciously agreed to inaugurate this event and chair one of the sessions. Thank you, sir, for your presence. Dr. Ganesh Mohan, our medical superintendent, has readily agreed to attend this function, but due to some unavoidable inconveniences, he couldn't make it. He has always been a strong advocate for enhancing laboratory facilities and services. He has taken the initiative to install several POCT machines in the hospital and has recently acquired a POCT toxicology analyzer in the casualty department. Thank you, sir, for your constant support. Dr. Geeta Nair, Deputy Superintendent, also couldn't make it for the function. I thank you, madam, also for her constant support. Dr. Binu Arikel, our nodal officer, IRC and SBMR, he's a committed researcher, academician, and inspiring leader, always ready to assist in all our activities. Welcome you, sir. Dr. Indira CK, who is always there at the forefront of all academic and non-academic activities and events in GMC Ernakulam, who always encourages all of us to participate in every institutional activities. Thank you, ma'am, for accepting our invitation to felicitate the event. I also warmly welcome our session chairpersons, Dr. Jacob sir, HOD Internal Medicine, Dr. Joanna madam, HOD Microbiology, Dr. Sajivan KC, HOD Department of Biochemistry, GMC Thrissur, Dr. Shibu TS, HOD Biochemistry, GMC Manjeri, and Dr. Jesse SJ, HOD Biochemistry, Government Medical College, Alappuzha, for accepting our request to lead various sessions. We are honored to have with us distinguished panel of guest speakers, Dr. Mabel Wesnick, Dr. Reshma, and Dr. Bishore, along with our in-house faculty, Dr. Rajesh and Dr. Ardra. They will share their expertise on diverse aspects of PSCT, ranging from cutting-edge technologies to quality assurance, clinical applications, and also other innovations. I am deeply humbled by the overwhelming response we have received since the announcement of this event. My teachers, friends, and postgraduate students from across Kerala have made the effort to be here today, and I thank each one of you sincerely from the bottom of my heart for your presence. I also extend my warm welcome to all delegates from other institutions and our own institution. Finally, I take this opportunity to express my heartfelt gratitude to all our patrons, organizing committee, faculty, staff, and students who have worked tirelessly to make this CME possible. And I extend sincere gratitude, and I also welcome Dr. Deepa Agustin, MU coordinator of Government Medical College Ernakulam, who is always a constant support for our all academic activities. Let us engage wholeheartedly in the sessions, exchange ideas, and strengthen our collective commitment to enhancing diagnostic efficiency and patient care. Once again, I warmly welcome all of you and wish you a productive and enriching CME. Thank you.
Thank you, ma'am, for your kind words. Next, I invite Dr. Anil Kumar, Vice Principal and Principal in Charge, to deliver the inaugural address and for the inauguration.
Dr. Jilsa is presiding over this session. Dr. Binu, Dr. Indira, Dr. Deepa, other dignitaries on and off the dais, colleagues, my dear friends. So, let me first of all congratulate the Biochemistry Department for conducting this CME. Actually, as far as I know, this lab week was there in the April, which is supposed to be celebrated. And yesterday as well as day before yesterday, we had a lab professional CME, and this that including all the lab professionals and technicians, and that is also, and this is actually a continuation, and I'm very happy to see. And yesterday when I came, somebody told me that we should more beautify this hall with tiles and all. But I am surprised to see this very beautifully arranged with red carpet for welcoming all of you, and really wonderful for that. And let me tell that this is very important concept. And myself is an example of at least myself is an example of the ignorance about it, because yesterday only I asked Dr. Rajesh what is the concept is about, and then only I had this idea of what is happening, what is this all is about. And I'm sure this POCT is going to reduce the cost of the patients, improve the patient care, reduce the hospital stay, improve the patient, the clinicians' diagnostic time, and definitely improve the outcome of the patient. So I know this, we are running short of time. I see a lot of talks to back to be finished. So hence I finished my talk, and I officially inaugurate that this CME is inaugurated. Thank you.
Next is a lamp lighting ceremony. So let us all stand up for lighting the lamp. The lamp symbolizes knowledge, which is the best friend for a mankind. Next, I invite Dr. Binu Erakulam, Nodal Officer SBMR, Professor and HOD, Community Medicine Department, for the felicitation.
A warm good morning to all of you, respected Anil Kumar sir, Dr. Gilsa, Indira madam, MU coordinator, Miriam madam who is on. So I'm extremely proud that Biochemistry is conducting a program on POCT. But I am with you, Anil Kumar sir. Today morning I asked Dr. Minu, it should be an interesting topic, what is POCT? She immediately told me it's a full form of point of care. Oh, maybe next time we conduct a CME, it could be in whole letters, right, for non-departments who doesn't understand. But from a public health perspective, it's an extremely important topic, because point of care means we get to rule out diseases, rule in diseases, where it could be critical. A patient coming with COVID, rule out COVID, he could be in the general ICU. So point of care is extremely important, but I think the most important concern from an epidemiologist is the accuracy of these results. That could be the rule breaker for any POCT. Quality control, as I heard in the last session, now they are using split samples. So to what extent quality control could be sanctioned, strictened in a government setting, in a private setting? I hope the CME would bring out inlights into those kind of things, I hope. So best wishes to my friend, and Gilsa, congrats you on conducting a beautiful CME. This could be a benchmark for future CMEs in Erakulam, I hope. Thank you.
Thank you, sir, for your kind words. I invite Dr. Deepa Augustine, MU Coordinator, GMC Erakulam Unit, for felicitation.
Respected Anil Kumar sir, Vice Principal and Principal in Charge, Dr. Gilsa, HOD of Biochemistry, Dr. Binu sir, HOD of Community Medicine, Dr. Indra, HOD of Anatomy, and all the delegates present here, warm good morning to all of you. Actually, I would like to congratulate the team Biochemistry led by Dr. Jilsa for conducting the CME. I think this is the first CME by the Biochemistry department from our college. Am I right? First one-day CME in this college. Give them a big hand of applause, and I am happy to see all the external faculty and delegates here filling the hall. And after with last 2 days, I think yesterday and night also it was heavy rain, but today it's a pleasant climate. And the field of diagnostics is evolving at a breathtaking pace, and point of care testing has truly emerged as a game changer, bringing accuracy, speed, and accessibility right to the patient side. So today's CME is a testament to our commitment to staying abreast of these advancements and ensuring that our knowledge translates into better patient outcomes. I once again congratulate the whole biochemistry team, and I thank Dr. Jilsa for inviting me. Thank you.
Next, I invite Dr. Indira C.K., Professor and HOD, Department of Anatomy, GMC Erakulam, for felicitation.
Respected Vice Principal Sir, Dr. Vinu, Dr. Deepa, all the distinguished guests who have assembled here. I thank Dr. Jilsa for inviting me also. In the history of GMC Erakulam, this is the first of its kind, a conference conducted by Dr. Jilsa. And I am really amazed to see the total number of participants also coming all the way on a heavy rainy day to Erakulam to participate in this CME. Speaking about Dr. Jilsa, we had been working together in 3 colleges at Patananthitta, at Idiki, and finally at Erakulam simultaneously at the same time. So I know her caliber. It is like we don't underestimate her capacities. She is a really efficient professor. She is an expert in MU and she is a versatile personality also. And GMC Erakulam is really should be really happy that they have an eminent and wonderful professor finally at GMC Erakulam. No, I should take this opportunity to say that because she is quite new and she is not that famous among, not that known to many of you at GMC Erakulam. So this is not an exaggeration, this is a fact which I have told about her, and you can expect much more and more from the Department of Biochemistry. Regarding POCT, like everyone, which is least known to non-clinical departments like that of us, and introducing all of us to what is PCOT is really fascinating, and we are eagerly waiting to hear the rest of the speakers. Thank you all for, thank you Department of Biochemistry for inviting me, and hearty congratulations from my behalf and on behalf of my department also.
Thank you, ma'am. Now I request Dr. Shajidha K S, Assistant Professor, Department of Biochemistry, GMC Erakulam, and also Organizing Secretary for the POCT Paradigm, to give a vote of thanks.
Good morning all. Respected Principal in charge Dr. Anil Kumar sir, Dr. Binu sir, our Community Medicine HOD and SBMR Nodal Officer, and Dr. Jilsa E.S., Professor and our HOD Biochemistry, Dr. Deepa Augustine, MEU Coordinator, and Dr. Indira Madam, Professor and HOD of Anatomy, and all other dignitaries of the dais and your colleagues. It is my honor to deliver the vote of thanks to each one of you for being part of this CME, the POCT paradigm, that is rapid, reliable, real-time POCT, revolutionizing diagnosis, organized by Department of Biochemistry, Government Medical College, Ernakulam. I believe that the sessions will be both enlightening and highly engaging. We are grateful for your presence in the college auditorium today, where we will explore the evolving landscape of point-of-care testing in healthcare. The sessions will highlight the significance of POCT in transforming clinical practice, enabling quicker decision-making, improving patient outcome, and enhancing workflow efficiency. First and foremost, on behalf of the organizing committee, I extend our heartfelt gratitude to our beloved principal, Dr. Anil Kumar sir. Thank you, sir. I would like to extend my sincere thanks to Dr. Ganesh Mohan sir, our medical superintendent. He is unable to come here because of some unavoidable program. I am thanking him for his unwavering support and guidance in making this event a reality. I would like to extend my sincere thanks to Dr. Binu sir, Dr. Deepa ma'am, and Dr. Indira ma'am for their kind words. I extend our heartfelt gratitude to all the distinguished speakers who will share their invaluable expertise and time with us. Thank you, Dr. Rajesh sir, Mr. Venugopal, Dr. Mabel Vasnaik, Dr. Adra Menon, and Dr. Reshma Regu, Dr. Bishor Ibrahim. I am sure that your presentation will be informative and thought-provoking and will shed light on various opportunities, challenges, and advancement in POCT, its clinical perspective, quality assurance, and biosensors in diagnostics. We are also profoundly grateful to the eminent chairs who will moderate the sessions and will guide our discussion. Thank you, Dr. Sajeevan sir, Dr. Shibu sir, Dr. Jacob sir, Dr. Joanne ma'am, and Dr. Jessie ma'am. Thank you, ma'am. I would like to thank you all the delegates who have assembled here for the sessions. Your presence and enthusiasm will reflect in the success of our CME. And deep depth of gratitude to our Jilsa ma'am, our HOD and organizing chairperson for conceiving and releasing the CME. Without her vision and guidance, this would not have materialized. I also extend my sincere thanks to my fellow organizing secretary, Dr. Needu CM, and the entire organizing committee members, Dr. Zainab, Dr. Soni, Dr. Mary, Srimati Blessy, Srimati Shiny, and Srimati Safia. Your dedication and hard work have been the backbone of this event. Thank you for ensuring every details was meticulously handled. I also extend my thanks to our DMLT student and especially Mr. Joyson, who have actively participated in helping us. Now I am extending my thanks to Kudalauthor team for their immense support. I will also like to thank you Vismaya Caterers for their delicious food arranged here. A special thanks to Mr. Riaz for arranging light and sound. I also extend my thanks to security officer for providing the support, and special thanks to Vishnu and team for arranging this venue so beautifully, and specially thanking Mr. Akbarika and other cleaning staffs for helping us. If I have left out of any of the name who helped us, I would like to take this opportunity to thank all of them. We hope that session will provide immense knowledge so that you can bridge the gap in POCT, implementation and patient care at your respective institution. Remembering each hands behind the scenes, once again, thank you everyone. Thank you.
Thank you, Dr. Shajidha. Thank you, dignitaries on the dais. Now we take a tea break and refreshing ourselves for the next session.
manage treatments, and ultimately improve outcomes. Seeing it through a clinical lens helps us appreciate both its potentials and its practical impact on everyday patient care. Please join me in welcoming Dr. Mabel Vasnaik, the chairperson, consultant, and head emergency department, Manipal Hospital, Bangalore. Dr. Mabel runs a busy emergency department in Manipal Hospital, Bangalore, which treats around 100 to 120 patients every day, coming with a variety of emergency illnesses. Dr. Mabel was the President, Society for Emergency Medicine, India 2002 to 2004, and faculty for the National Institute of Disaster Management. She was felicitated by the Nightingale's Medical Trust in 2004 for outstanding services rendered in the field of cardiopulmonary resuscitation. She is the chief editor of Essentials of Emergency Medicine and member of the editorial board of Journal of American Medical Association, JAMA, India. She has various publications to her credit and has authored chapters in many textbooks. Dr. Mabel is a member of the Review and Advisory Committee of Trauma and Clinical Care Guidelines to be developed by the Health and Family Welfare Department, Government of Karnataka. The Emergency Department is a recognized international training center under the American Heart Association for conducting basic life support and advanced life support courses. Dr. Mabel is the regional faculty for the American Heart Association. Dr. Mabel also runs a DNB program in emergency medicine. She has spoken at a large number of national and international conferences and has a large number of publications to her credit. Let's give a warm round of applause and welcome to Dr. Mabel Vasnaik for the next session. I invite Dr. Jacob K. Jacob, Professor and HOD, Department of General Medicine, Government Medical College, Erakulam, to chair the session. Dr. Mabel Vasnaik. Dr. Jacob K. Jacob has more than 25 years of teaching experience. He served as the MU coordinator in GMC Erakulam and has several publications in different journals.
Where's that mic?
I appreciate him for giving his valuable time out of his busy schedule to chair the session. Thank you, sir. I request all the speakers to be seated. All the delegates to be seated.
Dear delegates, please assemble.
Hi, can you all please bring your coffee and your snacks and come and sit?
Delegates, please assemble back.
Dear delegates, please assemble back. The session is about to start. Please settle down and assemble. The session is about to start. We're already running late. We are behind our schedule. Kindly assemble.
Warm good morning to you all. We have the next session that is Revolutionizing Diagnostics, the role of POCT in patient care, a clinical perspective. First of all, I want to appreciate the Department of Biochemistry, led by our Jilsa Madam, for arranging such a good CME, the first of its kind, and wonderful arrangement and good topics too. So once again, congratulate and also thank you for inviting me. Now for a clinician, as given in the caption, the results need to be very rapid. Decision making should be very rapid. My memories go almost 40 years before when we joined medicine. Even glucometer was a luxury, but now times have changed. We have patients who consume multiple tablets. What all tablets they have, they just consume. 1 month's tablet they will take. Then which which one to treat. So such problems we are facing. Even fevers. So the real-time PCR has come, point-of-care ultrasound, and point-of-care toxicology. Slowly these have come into our college also due to the efforts of our admins. So we have an expert speaker. She is an international faculty also, Dr. Mabel Vasnaik, and as mentioned, she is the chairperson, consultant and head emergency department, Manipal Hospital, Bangalore. I'm sure we will have a great insight into the topic. Welcome you, ma'am. Over to you.
Thank you, and thanks to the organizers for inviting me here. I request people who are with their coffee at the back, can you please sit down? Also request if you all can not talk, because then it's very distracting. Okay. So what I'm going to talk to you today is about point-of-care testing and how it's really revolutionized the way we treat patients in the emergency department. I'm Dr. Mabel and I work in Manipal Hospital, Bangalore. I've been working in the emergency department, first in St. John's and then St. John's, Bangalore, and then in Manipal Hospital from 1998. So it's like 30 years in the emergency department. And I worked at a time when we did not have point of care. And when point of care actually came to Bangalore, I was so happy. I discovered point of care at some conference that I went to. And then we got the ABG machine to the department, and then we got other cardiac biomarkers, etc., electrolytes, and it made such a difference to the way we treat patients. Can anyone tell me why it made a difference? Anyone? Why it made a difference to our treatment? Because our patients we were not, otherwise you're in a dilemma. A patient who walks into the emergency doesn't come with a diagnosis written on his face. So we're always confused, is it this, is it that? So having point of care in the emergency department makes such a difference because the diagnosis becomes clearer. It might not become 100% certain, but it definitely becomes much clearer. And if the diagnosis becomes clearer, then treatment of the patient starts much faster. And that is why point of care is so important. Now, I am not saying we should not send investigations to the lab. We do send investigations to the lab. So what do? We start with point of care. That gives us a good idea as to what's happening with the patient. Then eventually a sick patient will get admitted. When the patient gets admitted, anyway the labs are sent. Another thing that we follow in the department is we do regular controls with our point of care. Now, supposing when we do an investigation on a patient, we find an abnormality and it does not fit in with the clinical, with what we think clinically, we will then repeat it at the point of care and send it to the lab. So an abnormal result that doesn't look in sync with the patient's clinical condition, we do not, we don't we don't use that result. We don't treat based on that till we validate that result with the lab. Supposing we get a result and we are expecting something like that clinically, then yes. But so this is a safety net that we've built. So supposing you don't expect a low platelet at all and the patient has a low platelet, no fever, and old results have not shown a low platelet, then why should he have a low platelet? We have a CBC point of care. So then we will send to the lab to validate and see really, it's correct. Because our first dictum is do no harm to the patient. So based on a lab report, you can't treat a value that you are not very convinced with. So having said that, today we'll talk about understanding point of care testing, clinical benefits of point of care in patient care, implementation, challenges and considerations. Yes, we definitely have challenges with our point of care instruments, and a few case studies to actually understand how exactly as clinicians we are using point of care. Future directions, innovations in point of care testing. So, yes. So what are the clinical benefits in point of care, in patient care? It delivers diagnostic results within minutes crucial for timely clinical decisions. So within minutes, within like 5 minutes, within 10 minutes, what are the point of cares that we want in 5 or 10 minutes? One is the GRBS. Okay, so a patient comes to you, unresponsive. We're wondering what's happening to the patient. Has he bled in the brain? Is it a stroke? Is it a CVA? Or is it just hypoglycemia? So immediately when the patient like that comes to you, you do a GRBS. Now that's the simplest point of care that we're talking about. What about a sick patient with hypotension? Is he acidotic? Are his lactates high? So an ABG gives us a big insight into the patient. So ABG is a great point of care to have. So with ABG, you get your PO2, you get your PCO2, isn't it? Which is much better, the PO2 is much better than the SaO2. We also get lactates. We also get electrolytes. So you have a patient coming, his ECG is a little haywire, he's a CKD patient. What are you thinking of? He comes very breathless. What will go into your mind? Hyperkalemia, no? So is the patient hyperkalemic? You were saying something to me. The mic is okay. Yeah. So is the patient hyperkalemic? You start treating the hyperkalemia, but in addition to your ECG findings, your stat electrolytes will tell you what the potassium is. So in those ways, point of care is really helpful to us. So it helps us to make an early diagnosis. It also helps us to stabilize and treat in acute care settings. See, in an emergency, you don't have much time. The patient can decompensate. He can arrest on you. So point of care helps us to prevent that. If we send anything to the lab, with due respect to the lab, it will take time to come, no? First and foremost, someone has to go with it. We do have a chute. You know the chute where we send the vacutainers to the lab. Sometimes it will deliver on a wrong floor. Sometimes it will not reach, although that should not happen. Or we send our housekeeping with the vacutainers. They might go for coffee and then go. They don't understand the importance. So lab, even if the lab turnaround time, the lab gives us reports fast because we do flag it is from the emergency. There are so many logistics involved between the sample reaching the lab and then us getting the report. So in an emergency, when you want stat reports, I mean, I would swear by point of care. Okay. So improved response time, faster diagnosis would enhance patient outcomes. So advantages over traditional lab testing, it eliminates, like I said, transport delays. All the transport delays that we face. So many tests utilize capillary blood or urine. See, we need, your GRBS is a capillary blood. So a lot of tests are capillary bloods. So that prevent that, so even if you cannot get blood, if the patient is hypotensive, veins are not there, the capillary blood helps a lot. See, one big diagnosis that it helps us with is DKA. So earlier on, we used to wait for the patient to pass urine. Or you have to catheterize the patient to pass urine to see if there are ketones in the urine. So now we have plasma ketones. So all we do is poke the patient and you get the plasma ketones. So if the plasma ketones are positive, you know it is a ketoacidosis. The ABG you will do. So even before doing the ABG, you're not sure, you don't want to simply do an ABG. You can just poke the patient. When you poke the GRBS, you also get the plasma ketones. Plasma ketones are positive. Then you go and do the ABG, which is a more expensive investigation. Plasma ketones are negative. Then you can think of treating the patient as a uncontrolled diabetes. It's not a ketoacidosis. You know, you don't even need to do an ABG. So that way it helps us a lot. Otherwise you have to wait for the patient to pass urine, or you have to catheterize the patient. So the capillary blood is very useful. So so it streamlines workflow, etc. Now, what are the clinical applications? One is in emergency departments where I work. Like I said, patient comes with sick patients, very bad, very serious acuity. So we use it in the ER. ICUs also, it will be important. It can also be used, in mass gatherings, like if you have camps, etc. So you want to test diabetes, you want to do HbA1c. HbA1c also is now just prick sample. You can, the finger prick method, you can get an HbA1c. So it might not be as accurate as the lab. But what does it do? It gives you an indication. If your lab HbA1c is 6.6, this is not going to come as 5.6. So it might not hit the nail on the head like the lab does, but it's definitely giving you a rule in and a rule out, which with quite good accuracy. So so it's useful in remote settings and in chronic disease management also. So you don't have to keep testing the patient. You can just use this and you can test the patient. So you don't have to keep sending labs to the, you don't have to keep drawing blood. Okay. So in acute, another way it helps us is it decreases emergency department overcrowding. Now sometimes, especially when you have the dengue pandemic, lots of dengue cases when we get, the patient comes to us, fever, is it dengue, is it not dengue? They'll say fever 2-3 days. So we have a stat CBC. So the stat CBC tells us the whole HB, like a lab CBC, but it's stat, we get it in 10 minutes. So it tells us whether the total count is low, it tells us whether your platelets are low. So it gives us a good baseline. So then we think, yes, it can be dengue. We don't really have malaria in Bangalore. So we think it can be dengue, and then depending on how long the patient has had the fever, we would say repeat the test in the lab, or come back to us and repeat the test maybe in 2 days, in 24 hours, or in 48 hours, depending on how long the patient has had fever. And on the 3rd day, we'll say do the dengue panel. So it prevents overcrowding. Otherwise, if you're waiting for lab tests to come, your department gets so full of patients. I work in a 20-bedded emergency department, but sometimes when you have these dengue seasons and all, we put double trolleys, so 20 beds becomes 40 beds, and patients are so uncomfortable and so annoyed. So if we can do fast tests, it just helps the patients to be diagnosed, treated, and moved, those who don't need admission to the hospital. So it also is invaluable, I'm sure, in disaster situations. I've not really worked in a mass casualty setup outside, but I'm sure it is also would be very useful. So what are the types of POC devices? The handheld devices like the glucometers offer rapid results. Then we have the immunoassay technology, which detects specific molecules using antigen-antibody reactions for precise diagnosis. And we have biosensors and microfluidics. So one of the examples of the microfluidics is the point of care HS trop. So the high sensitivity troponin I that we do in the emergency departments uses microfluidics. So what does that mean? We need very little blood. We don't really need to draw a lot of blood. So even if it's difficult to get a lot of blood, then it helps us. So there are more and more point-of-care devices and technology that is coming, which is more sophisticated. And it is more accurate. It has better controls. So it reduces delays. So there is, like I said, you don't have to send the sample anywhere. So resource application. So there's another thing is many point-of-care devices, or most point-of-care devices, can be integrated in the HIS system. So if it's integrated in the HIS system, the clinician later, when the patient gets admitted, or if the patient comes back to the OPD, they can see what the tests that have been done in the ER. So earlier on, it was not convenient because they didn't know what our tests were. So now it can all be integrated. Yes, it comes at a cost, but it's well worth the integration. Having said that, in Manipal Hospital, we still have not integrated all the tests. So what do? We scan the tests and we put it in the patient's file online. I mean, in the patient's HI system, we scan the tests. All tests, even if it's because all these POCTs, except glucometer, comes with a printout. So the printout can easily be scanned and put into the patient's file so that the next person, when the patient comes for a follow-up, Normally they won't come for a follow-up to the ER, They'll come to the OPD. So the doctor in the OPD can know what exactly was done. Because very often patients lose their reports. So if it's in the system, it's so much easier. Yeah. So let's just see the challenges that we faced in implementing point of care. It provides rapid diagnostic results, like I said, directly at the patient's bedside and reduces waiting time. However, it may not handle complex tests as thoroughly as traditional laboratory methods. So, in a very sick patient, like I said right at the beginning, even though it gives me an idea as to what's happening, it might not be as accurate as the labs. So that is the drawback. And we must remember that as a drawback. Now, a lot of people say then you're charging the patient double. You're charging the patient for doing the point of care. And then if you're sending it to the lab, you're charging the patient again for it. But what's important? It's safety of the person. No, that's important. So appreciating the advantages of point of care and that it actually helps us to decrease morbidity and mortality very drastically because we get reports fast. We do also send to the lab because we feel that in complex cases, we need to have more accurate and, the lab values. And stringent quality assurance protocols are essential to maintain accuracy. I know labs do very stringent quality assurance protocols. What are we doing with our point of care? We have controls. So we do the controls. But unless you have someone to control that and to monitor that, it's not done. Like recently means day before yesterday, in the morning, we were doing HS drop. We do a lot of HS drop because we get a lot of patients' chest pain. So 3 HS drops didn't give us a proper result. Okay, so I was thinking, my God, I must call Venu and ask him, what's happening with your HS drop? So we said, okay, send it to the lab. Then the nurse in charge came back. She had gone for a meeting. And when she came, she noticed that each time you change a box, you must change the chip. You must put the new chip. And my nurses had not put the new chip. So we got wrong results. So those are the challenges. We ourselves have to be aware that, and we've been using that for such a long time. So when I ask them, why didn't you change it? No one gives a proper answer. So it can't be left to each one's, assuming that each one's going to be responsible. So now we put another thing in place and they have to sign when they take a new box and, when they insert the chip. So there are a lot of not only controls, but there are other such challenges that we face when we use point of care. So it depends on the individual department to iron out those challenges or to overcome those challenges. So the primary performers are the nurses because they conduct many of the POCT at the bedside. And they have to be competent, they have to be trained. So each time, there's so much turnover, no? The nurses come, then the nurses change. We get a new nurses coming ever so often. So each of them have to be trained in every device that we have in order to prevent this, in order to prevent these errors, which does not happen in the lab because the lab has stringent controls in place and a process in place. So all these are the challenges in the emergency department. Yes, so obstacles, maintaining test accuracy and reliability outside the controlled environment of central labs. So it's not a controlled environment. And there is continuous need to continuously retrain the operators, that is our nurses or our doctors, to minimize errors and ensure consistent results. See, even though I have been using HS drop for so long, it didn't strike me that I must check if the chip has been changed. And if you ask me, I don't even know where they actually change and put the chip. So I was so annoyed that day that 3 results came wrong. And then I said, no, then just teach me, let me do it. But then we should also know it ourselves. Unless you know it yourself, then you can't troubleshoot. So, and the other thing is, it is challenging also to integrate these POCTs into our main HIS system. So that's also a challenge, and that needs to be done. So there shouldn't be a risk of over-reliance on PCT results without confirmatory testing. You have to confirm with the lab. When your initial stuff is done, confirm with the lab, unless you're clinically sure of what is happening. Okay, so that's important when you have PCTs. So device calibration is important, regular device calibration which is done, controls have to be run, operator proficiency and adhering to regulatory guidelines also have to be done. Like NABH and all has regulatory guidelines where it comes to point of care. So it's very important to adhere to that. Why is it important? In the end, who's important? The patient. So all of us, labs, ER, everybody is interested in doing the right thing for the patient. Unless we have stringent methods in place, we might not always be able to do the right things for the patient, which is not correct at all. So training and competency, comprehensive training, result interpretation. Like in the first talk you were talking of, no? How do you interpret results? So the lab results might not be same as the results that we get. So we look at our normals, whatever the device normal is. And the lab might have their own normals. Okay, so that variation might be there. Not for all devices, but for some devices. Like our CBC machine, we tested it in our CBC machine as well as in the lab, the same sample. And we got very accurate results. But some point of care devices have different ranges. So, and different maybe, what is that called? The MM or whatever is different. I'm not getting the word. So, you know, we need to know how they're calibrated. Yeah, so safety protocols, adhering to safety protocols, very, very important. Cost effectiveness. So initial, it is cost effective because most of point of care devices, we're not really buying. It's reagent rental. So you're not doing the initial investment to buy it. You're paying for the reagent and you're paying for the test. And you don't need special people. It's the people who are there in the department, in the ICU, in the ER, who are doing the tests. So that way it is cost effective, doing these tests. The tests might be a little expensive, but considering the benefit you get, I would say it's definitely cost effective. So maintenance, supplies, training must be factored when you're actually costing for it. And important is improved patient outcomes and streamlined workflow and preventing overcrowding, especially in the ER. If you're preventing overcrowding, it is, that itself makes it cost effective. So I'll quickly go through a few case studies just so that, it's real time how we actually use this point of care. So I thought I'll start with this patient. He's a 62-year-old male. He came to us, he was hypertensive, diabetic. He came to the emergency department with acute onset of retrosternal chest pain, radiating to his left arm, accompanied by diaphoresis, shortness of breath. So what will you all think of? You all will think he's having an MI, right? So we did his vital signs were kind of all right. His BP was 160 on the higher side. He was hypertensive, heart rate was 98. But his ECG did not show a STEMI. So there was no ST elevation in the ECG. There were a few depressions, ST depressions, but it was not characteristic of a STEMI, although he was having chest pain. So to get him to get cardiology to actually take him would be challenging because he didn't have classic STEMI changes and his chest pain could be anything. So we'd have to do an echo, etc. So we did the HS drop, which showed a 35 nanogram per liter, which is high. Okay, but then HS drop might be high even in other conditions, in other cardiac conditions, not necessarily an MI. So then we repeated it. So it's important to repeat it. So when we repeated it, so before I come to what the repeat value, have I written the repeat value here? No. So it was elevated above the 99th percentile. I'll come to the 99th percentile later. So based on his history ECG findings. There was a high clinical suspicion of acute coronary syndrome. TIMI score showed that it was high. It was 4, the patient's TIMI score, but the serial trop came as 60. So there was the delta had increased significantly. So based on that and with his ongoing chest pain, we admitted the patient. Outcome was he went, so they took him for a coronary angiogram because his troponins had increased. It revealed, so the coronary angio showed a significant stenosis in left anterior descending, and he went to a stent placement. Now this was a patient who had ongoing chest pain, but you know, who had retrosternal chest pain, radiating, looked classical, although his ECG was not, didn't show a STEMI. But we get a lot of patients who come to us, they say chest pain, it's there, it's not there, you know, it's not classical. We have had patients who have come to us with chest pain, we've done an ECG, ECG was normal, we've done a bedside echo, we do the echo ourselves, no pain, give paracetamol, no pain, BP okay, we've sent the patient back. They've come the next day with a full-blown MI. So it is, and nowadays we're seeing younger patients coming with MIs. So we cannot just disregard when they come to the ER. So a trop and serial trops is very important. So if your trop is normal, your next trop, so you keep the patients. We keep the patient, we do the heart score, we keep him with us for 2 hours, we repeat an ECG, we repeat a trop. So if that also is within normal limits, then we can safely send the patient. So there's some patients who say, I had chest pain. We do a first trop which is absolutely normal. These patients we can rule out. We don't have to keep them. But patients who are iffy, those we repeat a trop. So, so the HS trop, high sensitivity trop, is better than the ordinary trop. Why? Because it comes positive within an hour of the patient, within half an hour, 30 minutes of the patient coming to you. So you can kind of rely on it. Or you wait and then you can also repeat it to be sure. So, so it's state of the art. The state of the art is high sensitivity troponin measurement. It's become the global gold standard for cardiac biomarker testing. And it can be made at very low troponin concentrations, and that's why it's important. So this is actually the single sample rule out. So patient presents with N-STEMI. So if a patient comes with ST elevation, we are not worried. We don't even do a trop in the ER. We shift the patient to cath lab. Will they do a trop? Yes. Then trops are done in the lab. Why are trops done in the lab? Because trops increase and then come down. So trops have to be done. So they are done in the lab. We don't need to do it in the ER. If we are very sure it's a, in a STEMI, we don't do it in the ER. It will be done later on. Because our values will not be the same as the lab values. They can't really compare. So this is an algorithm for very low HS trop. You can have a rule out pathway. If it does not meet the criteria for either of this, so high initial trop, you can rule in pathway, increases in 2 hours. So if it increases in 2 hours, the delta is more, then we admit the patient. Otherwise, we observe the patient, repeat a trop. So the ideal pathway is a combination of ECG, risk assessment, and biomarkers. Okay? So many patients, almost 80% of patients might not have ECG changes, but they're still having a coronary event. So that is why biomarkers and risk assessment is very important. So the common doubts, 0 and 1 hour troponin should be performed in the ER itself, because we don't have to send it to the lab, because we have the normals for what we are doing in the ER. So you do both in the ER and then make a decision. Okay, people ask, should we send, there's a doubt, should we send it to the lab? No. Manage in the ER and then send the patient. If it comes high and then you're admitting the patient, then once you admit the patient, they will anyway send the trops because they will need serial trops. The other doubt is POC and lab result will be different because the range of values is not the same. So there will be a difference. And in case you think that the POC is wrong, keep the patient repeat the test, especially in a high-risk group. Not only HS trop, anything. So the rule in and rule out, very low HS drops at presentation, particularly in patients with low pretest probability, you can easily rule out, rapid rule out. Patient is not hanging around in your department, is not overcrowding the department. You're not wasting his time, you're not wasting his money, you're sending him home. If there are higher levels, then you need a further investigation to rule in whether the patient is having a cardiac event. So if there is a delayed rule in, then the patient can have events. No, say he's having an MI, he's having a coronary event, and you're keeping him in your ER instead of sending him to the CC or sending him to the cath lab, then you can have an event. You can have arrhythmias, you can have fatal arrhythmias. So why would you keep him? So delayed rule in can affect the patient. You'll understand what I say delayed rule in. Delayed confirmation that it's an MI. A delayed rule out, if you are not sure and you're keeping him and you're repeating ECGs, and a delayed rule out just overcrowds your department, it stresses you, because instead of focusing on a new patient who has come, you're focusing on somebody who you can actually discharge. So it contributes to overcrowding. And there are some articles about rapid rule out of of acute myocardial infarction with a single high sensitivity. We also use point of care for diagnosis and treatment of acute and chronic heart failure. So what do we use for heart failure? So when you get a patient who's breathless, either you don't know respiratory, cardiac, is the patient in heart failure? It's important to know. You need to stabilize the patient. Clinically anyway, we'll start stabilizing the patient, but then you need to admit the patient. So it's important to know, is the patient in heart failure or not? And a very good tests are the natriuretic peptides. So you have the NT-proBNP or the BNP that can be used. Having said that, you need to know, because as you grow older, and some patients will have a high baseline. So you have to go from that. But it's an important test in the ER for us to rule out or rule in a heart failure. What else? Coming to our D-dimer. D-dimer is a very important, is an important test. Now D-dimer, for what? Can you tell me? For PE. So if you're suspecting a pulmonary embolism, we do a D-dimer. However, you also have to do your other scores. The D-dimer is not absolute. It just helps point towards a PE. Okay? So, but it's an important test to have in the emergency department. This is another point of care. So, there are just two more cases. 35-year-old woman came to the ER with abdominal pain and fever since the last 5 days. Altered sensorium since the last 12 hours. So, what do you think about this case? Can someone tell me? Heart rate was 120, BP 80/50, respiratory rate 30, saturation 90 on 15 liters of oxygen. Do you think the patient's hypotensive? Yes, isn't it? High heart rate, low BP. So, patient's hypotensive, something is happening. Are you happy with the respiratory rate? No, the respiratory rate is so high. Saturation is low. Patients on 15 liters of oxygen. Okay, so total count, ABG showing metabolic acidosis. So it helped us having an ABG there. Immediately we got to know metabolic acidosis. If I'd sent it to the lab, it would have taken half an hour. Total count is 15,085% neutrophils, serum electrolytes with the normal limits, chest X-ray, basal opacities, IV bolus of crystalloids was given. We had to secure the airway. So we had to intubate the patient. Then what? Should we do an abdominal CT? Should we do a neuroimaging? So those are the dilemmas that we face. What is a point of care test? So what might have happened to the patient? What do you think? Sepsis? Okay. So how do we rule out sepsis in the emergency department? So the Surviving Sepsis campaign tells us that there are a lot of recommendations how you treat a patient who comes to you with sepsis immediately, and your ProCal is very important. So if you have a point of care ProCal, it definitely helps you in diagnosing sepsis. Again, the lactate. Lactate will help you with diagnosing sepsis. So these are all the different other tests you do. But having a lactate in the ER, having a ProCal is of tremendous benefit. This is a 25-year-old boy with fever since 2 days, rashes over his body, extreme fatigue, loss of appetite. What are you all thinking of? Are his vitals okay? Heart rate is 120. Why is it heart rate high? Because of fever. He has fever. Is his BP okay? Yes, 138. He's not hypotensive. Respiratory rate is okay. Saturation is okay. On examination, respiratory, cardiovascular, neurological examinations were all right. Abdominal tenderness, no guarding, but he had a history of nausea. CBC will take 2 hours to get the report from the lab. What are we thinking of in this patient? With fever. So he can have, and severe fatigue. He can have some kind of an infection. He can also have dengue, he can have malaria, he can have dengue. Okay, so a CBC will rapidly tell you, no, you'll see the total count, see if it's high, if it is okay, if it is low, you'll get the platelet count, you'll get the neutrophils, etc. So it gives you immediately, you can make some kind of diagnosis on this patient and start treating the patient in the ER. So this was a 39-year-old woman with fever and chills since a day, lower abdominal pain, increasing frequency of micturition. Yes, we did think that this patient had a urinary tract infection. But what if the patient had something else and not a UTI? If we send the urine to the lab, it will take time to come. Definitely 1 or 2 hours. So we have a urine analyzer in the department. It gives us whether there are nitrates, there are leukocytes. So we do the urine. Immediately in 5 minutes we get the report. And we are so happy, the patient is so happy, we've made a diagnosis. Then what do? We send a culture to the lab. We don't make the patient wait. So we send a culture, and urine culture, and we start treating the patient with empirical antibiotics. And we say, come back in 3 days' time, when your culture report will come, so we know whether the antibiotic we've started is normal or not. So to do this, waiting for it to come back from the lab will take so much time. Patient gets annoyed, they get restless, and our department gets crowded. CBC also. So in this patient, when you do a CBC, stat CBC, your counts will be high. So you know that the patient is some kind of infection. No? So if you do the urine tells you that it is a urinary tract infection, then you can start treating the patient. So just simple tests, but then it really helps us. Point of care does help us. So this is our department. This is the urine analyzer. This is a different point of test that we have. The triage meter also is here. Okay. So ABG, I've told you, we need for acidosis, for lactate. Then electrolytes. I gave you an example about a CKD patient coming to us breathless. You want to know the potassium. You tell the potassium. You want to know if there's a hypokalemia. Patients aren't moving his limbs properly. Is it a hypokalemia? Before the lab results come, you get your results and you can start treating the patient. GRB is important. HS-stop we've talked about. NT-proBNP. D-dimer. Serum creatinine. So serum creatinine is a very important test for us in the emergency department, because we get patients coming to us. Is it an AKI? So we can do an NGAL, but we need a creatinine. So many patients come to us, we have to send them for contrast CTs. Although you don't really need a creatinine for a contrast CT, the radiology still insists. So if we can do a stat creat in our emergency department, it helps us so much. So along with the ABG machine also gives us creatinine. So creatinine has really, getting a stat creatinine has really changed the way, the time that it takes us and our insight into a patient. So I put creat as one of our that's what we use in our department. We use the urine routine micro we have, CBC, serum amylase and lipase. So patient coming with abdominal pain, you don't know what's happening. We have a stat LFT and we have an amylase. So amylase, lipase, if it's raised, you know it's pancreatitis. If he's a known case of pancreatitis, it's different. But so many times, we would diagnose it first time with us. So much abdominal pain. So it helps us. LFT, CRP, again, are we going to give antibiotics, not give antibiotics, treat the patient in the ER and send them home and then tell them to come later on to the OPD. Okay? PCT, which I've told you, beta HCG. So if we have a patient suspecting ectopic, clinically apparent, fine. But otherwise, this gynae will ask for, they will want us to do an ultrasound, and the patient is unstable, we can't send for ultrasound. They won't just accept UPT. A high HCG, beta HCG is so important. So beta HCG, again, sending to the lab takes time to come. If we have a point of care beta HCG, it is very, very useful for our patients. So this is the use of POCT in the ER. This is what we use. It helps continuous monitoring of chronic diseases. Diabetes management is very useful. And anticoagulation. Yes, I forgot to write there, the PT-INR. So even in patients, we need to coagulate. Stroke patients, we need a PT-INR. So we have the PT-INR meter. I don't know how I forgot to write it in my list. So we have the PT-INR meter. So it gives us our PT-INR immediately. And then we can go ahead and treat our stroke patients. So during COVID, it was useful because we had the machine with us. So we would do in the Abbott machine, we would check whether the patient was positive or not. A rapid result, it helped in timely decisions. So it helped us diagnose even patients who were not really apparently very symptomatic. Lots of them would come and we would do the test and we would diagnose them and send them home and they could isolate themselves. So future directions, integration with digital health and connectivity. So if it has to integrate with digital platforms because then whatever is done is stored in the electronic health records and it will help in remote monitoring also. So there's a lab, there are emerging technologies, next generation POCTs, which I don't really understand too much, but I'll just go through it. The labs, you all will understand it better. So lab on a chip technology, wearable sensor. So like that, the continuous glucose monitors, no? If you have a wearable sensor, then it would help in diagnosing whatever needs to be diagnosed. And AI-powered diagnostics, I'm sure, are in the pipeline and have already started. So future trends is AI integration, molecular advancements, miniaturization and multiplexing, and for home and continuity care. So to conclude, PCO, the point of care is testing, enables quicker diagnosis, improves patient-related healthcare delivery, and it definitely helps us in decision making. Innovations and integration, there is ongoing innovations, healthcare integration, integration with the HI system, which will support personalized health management. And definitely in future of healthcare, in the ERs, in the ICUs, PCO, point of care, POCT is definitely here to stay. Okay? Thank you for listening patiently. Any questions, I'll be happy to answer. Anything you want to ask? Okay, so if you're not asking me questions, either you all have not listened at all or I have been clear. So hopefully I've been clear. Yes. You're most welcome. Yeah, so if a patient comes to you with heart failure, then we will do, if the patient is a pre-existing case, then the BNP will anyway, you'll have a baseline BNP, you'll know. So you will know how much it has risen from the baseline. So you know how much sicker the patient is. But if it's a new patient and the patient is breathless and you are not really sure whether it's heart failure or not, then we do a BNP or a NT-proBNP. So if that is raised, then we know we are dealing with heart failure. Or maybe you do a HS stop and a BNP. So it helps us mainly in diagnosing heart failure. Yes. It is quantitative. Yeah, it's quantitative. So we know the cutoff is there, and then we know whether it's 0.1 or it's 1 or it's 2 or whatever. There is a range. It is definitely quantitative. Yeah. I'll give you those articles. So if you go through the articles, it will make it very clear, the BNP articles. Okay, and the pathway. Yes.
Hi ma'am, thank you for the insights. What's your opinion about stat labs actually? Because recently I have seen, actually I have heard about the concept also, but I have seen a very beautifully set stat lab actually as a part of ER in the KOCHI Medical College, which has been set by one of our seniors, the Dr. Lakshmi madam. In that, she was providing the ER support with a fully automated bioanalyzer and some coagulation analysis and setups and sort of things also.
So what I showed you, I said this is from my department. This we have set up, we call it the stat lab.
Okay.
And we have set it up in one room. So all these instruments are there in the room. So when we want to do any tests, we go to this room and we do the test. Okay. I want to show you it got integrated with my, this is our department's.
So there is a
our ABG machine also.
So there was a kind of ER lab teamwork which has been propagated over there with a very good idea, because it is very nice to watch also, and they got a technical person posted over there for that thing only.
Okay.
And moreover, in the stat lab, we are having a concept of providing, instead of taking serum sample, wherever possible, having a concept of taking plasma sample also, especially the heparin plasma. It will reduce the TAT by nearly 30 minutes also.
Okay.
So those concepts, I mean, is it kicking on the
pipelines? So they have a lab person. We also asked if we could get a lab person, but our lab didn't have a person to give us over 24 hours. So all our we call it the stat lab, because all our instruments are there, but those are things that we can do, our doctors and nurses can do. So if the labs come, then they can definitely do maybe better,
Okay, as I told you, lab ER team of workers.
Yes, but we don't have, most places labs will not have people to send to the ER.
Okay, that's actually a private setup thing.
Yes.
They are propagating very much the stat lab, a part of ER. Thank you.
So even we call the stat lab a part of ER because we got to get everything that we want, but it's done by us.
Okay, thank you.
I'm surprised you don't have a myoglobin in your stat lab, because you kept saying that you repeated HS tropi. A myoglobin takes shorter period than tropi, if I am not mistaken.
Yeah, so we used to have myoglobin. So we had troponin I, myoglobin and CPK in the same panel. But now that we have high sensitivity troponin I, it comes it's more specific for the myocytes, and no, this comes much faster. The high sensitivity comes much faster than the myoglobin. Since I was not really talking cardiac, I didn't show those slides. But the HS drop comes positive much before the myoglobin. So we use myoglobin, but that's, when we want CPK and all, and then myoglobin. But you don't really use it for MIs anymore once we've started getting the HS drop.
Because our biochemistry books, texts say HS tropi within 1 to 3 hours, shorter duration myoglobin.
No, madam, that was troponin I, not high sensitivity. Okay. So our HS drop is very sensitive and appears much earlier than the myoglobin. So we actually changed that shortness of breath panel. We used to do troponin I, myoglobin, and CPK would come in one panel. So we changed that to individual. So we either do HS drop, or we do D-dimer, or we do BNP. So we don't use that panel anymore because we felt, pardon? It makes us and our PGs think, why do you want to do the whole panel? Otherwise they'll just say, okay, we'll do the whole panel. But why? If you're not suspecting heart failure, and then why are you doing an HS, why are you doing BNP? Or why are you doing a D-dimer? Just because it's there, don't do it. If you need to do it, do it. So I don't know how much cheaper it works out. Maybe it works out a little cheaper, I'm not sure. But at least we're doing specific things. So we've taken off the shortness of breath panel. I think it's cheaper also. Yeah.
Thank you, madam. It was an excellent talk. Two things. I think, am I correct? Ischemia-induced albumin, does it rise before HS tropi?
Ischemia-induced?
Albumin for ischemia, cardiac ischemia.
Ischemia-induced?
Albumin.
Ischemia-induced albumin? Yeah. I don't know. We don't do it. I'm not sure.
I read somewhere. Anyway.
Okay.
Another one is ammonia. Do we have a POCT for ammonia?
We actually don't have a POCT for ammonia.
Because we have a lot of alcoholic patients.
Yeah, we don't have a POCT. One of our people who, that ABG person who had come, we've been telling him, get us ammonia, because ammonia will be very useful to have. No, we don't have ammonia.
Yeah. Anyway, thank you, because also you have integrated with the clinical cases. Thank you, it was an excellent talk.
Thank you.
Thank you, Dr. Mabel. Now I request Dr. Jacob K. Jacob to present a memento to Dr. Mabel. I invite Dr. Sri Devi, former principal, TDMC Alapura, and principal of Mount Zion Medical College, to present a memento to Dr. Jacob K. Jacob. Madam, please. Thank you, ma'am. Thank you, sir. Our next session focuses on the critical area where point-of-care testing is making a real difference between infectious diseases and sepsis. Rapid, accurate diagnosis in these cases can be life-saving, helping clinicians start timely treatment and improve patient outcome. POCT's ability to deliver results quickly right at the bedside is transforming how we tackle infections and manage sepsis. I am pleased to invite Dr. Adra R. Menon, Professor Cap, Department of Microbiology, GMC Erakulam, to guide us through the latest developments and clinical applications of POCT in this vital area. Dr. Adra completed MBBS from GMC Thrissur and MD Microbiology from GMC Kozhikode. She has 19 years of teaching experience in medical colleges. Her field of interests are medical education, clinical microbiology, especially bacteriology, hospital infection control. She is an executive member of Academy of Clinical Microbiologists from 2024 to 27. She has published several research projects in national and international journals. I welcome Dr. Ardra R. Menon on the dais. The session will be chaired by Dr. Joanna Mary Magdalene, Professor and HOD, Department of Microbiology, GMC Ernakulam. Joanna Madam has done her MBBS from TDMC Alapura and MD Microbiology from GMC Calicut. She joined government services at TDMC Alapura in 1997. She worked as senior lecturer and assistant professor in TDMC till 2008, and then she was promoted as associate professor at GMC Calicut. She joined Cooperative Medical College, Kalamassery, presently GMC Ernakulam, as associate professor in 2008 and was promoted as professor in 2022. I welcome Joanna Madam to the dais to chair the session.
Thank you. May I take this opportunity to congratulate Dr. Jilsa and team for organizing such a nice CME, the first of its kind, as mentioned earlier, from the Department of Biochemistry in this institution. And I also thank the team for having invited me to chair this session. So we had been hearing about POCT from morning, and as we all know, one of the challenges or role of lab, especially microbiology lab, is early reporting of pathogens from blood and sterile fluids, which enable the clinician to start the treatment early, and so that the patient outcome is better or mortality and morbidity is reduced. But in microbiology, the conventional procedures like culture and sensitivity, though they are the gold standards, they are time consuming. So here is the crucial role of PCTs. But having heard of the quality assurance programs or importance of maintenance of quality in the second session, we know that it is not as simple as we think. We have to maintain the quality of the PCTs, otherwise it may do harm than good. Anyway, we'll hear more about POCTs in terms of infection and sepsis from Dr. Ardra, our Associate Professor in Microbiology. Over to you, Ardra.
Okay, thank you, Madam. So I take this opportunity to thank the organizing team and especially my friend Dr. Jilsa for giving me the opportunity to talk in this CME. So as all of you have mentioned, my speakers have mentioned before, and as all of you know, this is a very important topic. So the point of care testing in infectious disease and sepsis is very important because sepsis and infectious disease requires immediate management, especially sepsis requires immediate care and management, especially in OP and critical care settings. So my talk will go through these points. Prevalence and global impact of infectious disease and sepsis, the WHO criteria already mentioned by Dr. Rajesh, biomarkers and technologies in infectious diseases, some of the biomarkers used in sepsis, the implementation challenges, innovations and future directives. There will be some overlaps because the point of care testings, the topic is actually quite small in a sense. There will be some overlaps of some points, bear with me. So the prevalence and global impact, as all of you know, the infectious disease plays a very major contributor to global illness and death. So this is the IHME data from 2024. This shows that even now in 2024, the infectious disease, especially tuberculosis, HIV, endemic disease, this still impose a global burden to the public health. And they cause sepsis, which is, as all of you know, it is a severe complication of infection. That contributes, according to WHO, it contributes to about 20% of global health. And it requires early diagnosis and treatment in order to improve the patient outcome. So that is very important. And not only that, because both of them, you give antibiotics. If the diagnosis is not accurate, what happens is that you give large amount of antibiotics, you give broad spectrum antibiotics, you may give antibiotics which are not targeted. So it can lead to antimicrobial resistance, increased hospital stay, increased hospital burden, increased economic burden to the patients, and it all contributes to the global impact of antimicrobial resistance on human health. So it all contributes to the antimicrobial stewardship programs. So there's a saying that without diagnostics, medicine is blind. I can change this, that it is without accurate and timely diagnosis, medicine is blind. And so only if with that we can give early recognition, resuscitation and targeted antimicrobial therapy. So that is very important in the case of infectious disease and sepsis, not in almost all cases. So as already Madam has mentioned, the microbiology test, all of you would have said that 2 days, it will take 2 days, 3 days for the test results to come, especially in the case of culture. In most of the diseases, culture is the gold standard. In now some of the cases, molecular tests are the gold standards, but it requires infrastructures. Infrastructure, it requires skill, it requires expertise, it is cumbersome procedure. So what happens is that it requires time, which is not in the present modern era. We need the results at the fingertips. So that is not occurring. So we need the point of care of test. There comes the importance of point of care of test. So already mentioned, it is the decentralization of test. That is, we are bringing the test from the lab to the patient bedside. There are a lot of different names for point of care tests, like the bedside, decentralized, off-site, physician office-based testing. These are all the names of point of care testing. Now, already mentioned, that's why I told you there will be some overlap. I'll be telling in the basis of infectious disease and sepsis only. So there is, as I already told you, the turnaround time will be less. Because the turnaround time is less, you get the results within minutes, sometimes within hours. So what happens is that you can give the patient, the clinician can make the decision immediately. When the immediate decisions are made, that in the case of infectious disease and sepsis, targeted antimicrobial therapy, so that means it is better for the patient. So there is less antimicrobial resistance. For us, the infection control measures are better. So it is better for the patient because in a sense, there is lesser hospital stay, less economic burden. It is more cost effective and also better patient gratification. Sometimes the patient gets discharged from the hospital itself. And sometimes in some cases like dengue and all, there is no need for antibiotics also if you are diagnosing it there and then itself. And most of the point of care tests are made in such a way that it is designed in such a way that it is portable and it can be ease of use is there. So it requires minimal expertise. Not all point of care tests, but some of the point of care tests, it requires minimal training requirements and ease of use. So, and most of them can be used for surveillance in community also. So all of these are the advantages of point of care test. Now, already mentioned by Dr. Rajesh, I'll just go through that. For the designing of a point of care test, this is the WHO assured criteria: affordable, sensitive, specific, user friendly, rapid, equipment free and deliverable to end users. So now there's a Dr. Pai, he had classified the point of care test according to the point of care testing end users and technology into 5 groups. When the group, the number ascends 1, 2, 3, 4, 5, the technology increases, the expertise needed increases, the infrastructure required increases. So the basic ones are the one which is home based. So you will remember during the COVID time, we used to do COVID testing at home, or the pregnancy test, if I'm just pushing aside the sepsis and infectious diseases, those tests, those are all belonging to the home-based test. We can do at home, which doesn't require that much expertise. Which communities means which is done by the village workers, okay? Then the clinics, peripheral lab hospitals, that requires some infrastructure, some amount of electricity, some expertise to interpret at least. So most of the point of care actually belongs to 4 and 5. It is not, it doesn't belong to most of the criteria, doesn't fully fulfill all the 4-5 criteria of assured. So now we'll go to the infectious disease as such. What are the biomarkers which are used in the infectious disease? As all of you know, infectious diseases are caused by pathogens. Pathogens have got molecular markers, means they have got DNA or RNA. So DNA or RNA, that nucleic acids are there. So that is now the current thing is molecular markers. So we have got molecular markers as point of care test now. Only thing is the cost. Cost is the one that you can't afford in the, if you are using molecular markers, and you need some amount of infrastructure for that. So that is the only thing that is, and some expertise. But you can't use the normal real-time PCR as a point of care test. That requires completely different infrastructure and skill. But you can use the TrueNat. TrueNat was the one which is utilized by the NTP. That is a portable that you can use in the peripheral health center or the NTP programs. We can use that. It requires a battery operated machine that you can use for the diagnosis. Not only for tuberculosis, you can use it for other diseases also. So TrueNat is a point of care test, PCR based amplification automated machine that we can use as a point of care test. Whereas CBNat, it is a near point of care test. There are some terminology called near point of care test, means it requires some infrastructure and skill, but it has the accuracy and diagnostics, increased diagnostic accuracy, and speed also is there. So that means it's near point of care test, but it requires things. But it's CBNat is mainly for tuberculosis. Then you can, because in order to do away with the thermocyclers, there are isothermal amplification methods also, point of care, but we are not using that as point of care test as of now. Then we have got the antigens and antibodies. That is the one that we are mainly using, the CAR test that we are using, antigens and antibodies, antigens of the pathogens and antibodies against the pathogens. So that we are using, most of the tests we are using are the CAR tests that we are using. Antibodies, only problem is that antibodies, there will be window period, so it will sometimes take time taken, so we may miss the diagnosis. And there is sometimes cross reactivity, and sometimes antibodies can remain long. So antibodies, the sensitivity and specificity of immunoassays can be, sometimes it can be a problem. Then we have research is ongoing for the circulating microRNAs for tuberculosis and HIV, and the sepsis biomarkers can be used in conjunction with the infectious disease rapid test to aid the diagnosis. So the first three, these first three are the one that we mainly use for the biomarkers as infectious disease, as all of you know, and of which the antigen and antibody we mainly use the immunoassays, that is the immunochromatography and latex agglutination, and the molecular assay, as I told you, TrueNat. Only TrueNat is the actual point of care test. CBNat and film array is near point of, but they can be included in point of care. The only thing is that ICT and agglutination, the CAR test and latex agglutination, it costs 500 rupees per test, 500 to below 1000, whereas CBNat, TrueNat, it costs 2500 rupees per test. Starting, I am telling you, film array, it's a syndromic panel, it costs 15,000 per test. So the cost is a problem. Cost is a problem other than the infrastructure. So these are the, just mentioning some of the point of care tests in the infectious disease that can be used at the emergency or the bedside. This is very easy CAR test that is available in the market. Pneumococcal from the sputum, urine, etc. Group A, Group B, MRSA, COVID that we have used. These are the virus, these are the fungus, these are the parasites that we are using. You must be familiar with at least some of the names. Latex agglutination, this is for the CSF, bacterial meningitis panel, and the cryptococcus panel, cryptococcus meningitis. And the point of care that I told you, 2 hours, within 2 hours. I just wanted to mention this one. This was a newer one, Cobas Liat. This is by the Roche Diagnostics. This is not available in India as of now, but this within 20 minutes, point of care, bedside, physician-based testing, within 20 minutes from the sample for these organisms, SARS-CoV-2, influenza A and B, respiratory syncytial virus, and group A streptococci. From the patient sample, you can get the result within 20 minutes. So this is used in Europe and US and even in the Middle East. It is available. It is, as of now, it is not available in India. It will be costly, but the result is 20 minutes. Within 20 minutes, it is available. The results are available. It is a point of care test because the processing time is very little. 5 minutes they are telling the processing time. So this is the film array panel. Now, the real life examples for HIV, you know, lot of programs we are using the CAR test. HIV, SACS, KSACS, NACO. We are using the CAR test for the diagnosis, for the management, for the this we are using. Malaria program we are using the CAR test. Even though microscopy is the gold standard and the sensitivity and specificity of the CAR test is not that good, we are still using this because of the ease of use, and we can in the field it is very easy to use. So to define the treatment, because we can differentiate between falciparum and vivax, and we can use this. So CAR test are being used. Again, tuberculosis, I told you we have done away with the microscopy. We are using the TrueNAT and SIBNAT because we can find out resistance also along with that. So that is very important. Very easily we can do resistance. So that is the National Tuberculosis Elimination Program, NTP. We are using the TrueNAT. So that is also there. So lot of programs are also using these things. So this is just about this infectious disease. Sepsis, as you know, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated, that's the definition. It is the infection, dysregulated host response to infection. So the mortality, the only thing is that sepsis requires immediate antibiotics treatment. So the mortality increases 7% per hour with delay in antibiotics in the case of sepsis. So sepsis is a race against time. Each hour counts in the case of sepsis. So only thing is that the gold standard in the case of sepsis is culture only, blood culture. But as all of you know, blood culture takes time. Blood culture takes time. It takes time. Even with the automated method, 24 hours, 48 hours, it takes time for the blood culture. And suppose you have given antibiotics to the patient, the yield is low. Even with that, 30% only the blood culture turns positive. Some of the fastidious organisms will not grow in the blood culture. So the culture may not turn positive. Okay. So in that cases, we need some markers. WBC, CBC you can do. Other than that, you need some markers for diagnosis of sepsis. Already madam had told the markers for sepsis. Lot of markers are there. The main markers that we use are lactate, procalcitonin and CRP, which helps in identification of sepsis. So as I think most of you will be knowing that we have in the 2016 they have done away with SIRS and SOFA score has been included for the identification of sepsis. SOFA means sequential organ failure assessment. 6 systems they are using 6 systems: respiration, platelet count, liver, heart, neurology, renal. And they don't need biomarkers to diagnose sepsis if you are going for this SOFA score. Actually, to diagnose SOFA score. And in order to bedside SOFA score, they have got a Q SOFA score also. So that even doesn't require WBC count. They require altered mental status, respiratory rate and systolic BP. But the problem with these scores are that they are not specific. So they may need multiple measurements. And they may misdiagnose in case of 30% cases, and unnecessary antibiotic use will be there. So we may sometimes have to use biomarkers in conjunction with this in order to facilitate easy diagnosis or early diagnosis of sepsis. Okay, so that is how the sepsis comes. I hope you know a little bit of sepsis. I'm not going to the detail of sepsis diagnosis. Just want to know how the biomarkers come into how we are looking, why we are looking for CRP and procalcitonin. As you know, when a pathogen comes into the body, be a bacteria, virus, whatever it is, mainly bacteria, when it comes into the body, bacteria comes, it has the lipopolysaccharide. So what happens, especially gram-negative bacteria, it comes, it will enter into a cell, host cells. The host cell starts to, the innate immunity comes into place. The immunity starts to release cytokines. So pro-inflammatory cytokines, especially tumor necrosing factor alpha, interleukin 1, interleukin 6. Interleukin 6 plays a very important part. This interleukin 6 goes and triggers liver. From the liver, CRP comes. From the liver and other tissues, procalcitonin comes. So bacteria, cytokines, interleukin 6, CRP, procalcitonin. So that is how CRP and procalcitonin we are measuring as a marker of sepsis. Bacteria marker right, we are measuring CRP and procalcitonin because it is triggered by the it is raised by the influence of interleukin 6. Interleukin 6 can also be measured, but very few tests are available. So these are all markers of sepsis. I am not going into details of that. It is beyond the scope of this discussion. We are only discussing about the things that we are using now. So CRP. CRP, very commonly we are using CRP, C-reactive protein, acute phase reactant produced by the liver. And more than 6 milligram, more than 10 milligram per liter or more than 1 milligram per deciliter we are usually considering. According to the kits it may vary. In our lab we are giving more than 6. So it depends. Depends upon the kit and all. So there is we look at the area under the curve. I'm going to definition under area under the curve to how this marker can differentiate between sepsis and non-sepsis. So if it is nearer to 1 means it is a very good marker. So here CRP, the marker is 0.76, that is almost nearer to 1, so it's a good biomarker to differentiate sepsis from non-sepsis. Now the only problem with CRP, as all of you know, it is a non-specific marker. It will raise in lot of other cases like trauma, surgery. The main thing is it can increase after surgery. So just after surgery, if you look for CRP, CRP will be raised. You don't know if it's because of infection or because of surgery. It will take time for the CRP to normalize after surgery. Time because the surgery can trigger the release of CRP. So that inflammatory, so it is very less specific. Specificity is very less for CRP to diagnose or to make a diagnosis of sepsis. And it cannot differentiate bacterial and viral infection. That is one point for CRP, against CRP. Whereas procalcitonin, it is a prohormone released by liver and various other tissues. As all of you know, procalcitonin can aid in whether to start or stop antibiotics. So 0.5, that is a cutoff, 0.5 nanogram per ml. Clinicians here will be knowing 0.5 nanogram per ml. That is a cutoff to detect sepsis or not sepsis. And the levels increases, the degree of sepsis also increases. So very important. So as you know, less than 0.5 nanogram per ml, no sepsis, more than 5 sepsis. And that gives the cutoff. So here the area under of the curve is 0.85. That means it's a better marker than CRP. The sensitivity and specificity is also high, 73 and 77%. That is also good. And another thing is that when the level of procalcitonin increases, when the procalcitonin level increases, there is high chance for gram-negative sepsis. If the level is more than 2 means it is high chance of gram-negative than gram-positive sepsis, studies have shown. And also, it is mainly seen in bacterial infections. So procalcitonin can differentiate between bacterial and viral infections. It is not raised in viral infections because in viral infections, interferon gamma is released, not tumor necrosis factor alpha. That the cytokine difference, it is because of that. So it is mainly increased in bacterial infections. So it can differentiate between bacterial and viral infections. So that is one important thing about procalcitonin. And you have got kits which can give quantitative semi-quantitative method detection kits are there which can give markers for 0.5, 2, 10, like that lines will be formed accordingly according to the level of procalcitonin in the blood. So you can easily use this as the POCT test, and as I told you 0.5 nanogram per ml that we can use. If it's less than 0.5 or less than 80% of the last peak concentration, you are testing it after 48 hours. Suppose usually the patient will be, it is not point of care at that time. At that time the patient has gone to the ICU or whatever it is. After you are testing, sepsis diagnosed, patient has gone to the lab. But this even in the ICU, you can do it at that time at the point of care test, whether to diagnose, whether to determine whether the patient has improved, whether you have to change the antibiotics, whether you should stop the antibiotics, whether the antibiotics have to be increased, whatever it is, changed or combination, whatever it is, that 0.5 nanogram per ml, that is a very important marker in the case of procalcitonin. Then again, lactate. Lactate is another biomarker. It is sepsis early because tissue hypoxia, it gives tissue hypoxia. Like the glucometer, lactate strips are available that can be used as point of care test. So lactate is also a very important marker for sepsis. So these are the three biomarkers. The only thing from literature what I have read and what I have understood is that no single biomarker is actually useful. You have to use it with clinical correlation, and also to one or two biomarkers together may give a better approach to diagnosis than a single biomarker. Now this is another important, this is an advanced one, newer one, septicide rapid. This is a molecular, everything is now molecular, isn't it? So it's a PCR based septic diagnostic thing. It can give a result within 1 hour. It can differentiate sepsis with non-infectious SIRS. Okay, so this is this is an FDA approved 2021 kit. It can be used, it's very easy to use, can be used as a bedside test. Bedside means physician based test near the office, very easy to use, fully automated, sample, single cartridge, very easy to use test. Initial investment will be there, test will be costly, but results are actually supposed to be good, very good. It is by Immuno Express company, so it is good actually. Now, so what happens? So this is the comparative diagram, it's a mermaid workflow in the case of emergency settings. A patient arrival, the sample collection, you do a rapid testing for either antigen, infectious disease, molecular workup, sepsis biomarkers, whatever you want to do. Immediate result interpretation, clinical decision, initiate, treatment, whatever you want, immediate. That is the importance of point of care testing. Immediately you do the testing, immediately you decide whatever you want to do. If you want to do additional testing, you decide immediately there and there. If you want to send additional testing to the lab, the facility is not available in the emergency department, you send it to the lab. That is also there. Then patient management and data integration with the electronic medical record. The documentation is also very important in the case, because further management depends upon this documentation. Now the implementation challenges already mentioned. Whatever I have mentioned as advantages, here ulta comes. What is that? Even though we say that it doesn't require that much infrastructure, for infectious disease at least, we need some infrastructure. Especially for molecular tests, which is the current diagnostic criteria, we need some infrastructure. For the reagents, for the diagnostics, the kits, some infrastructure, some sustainability, electricity, something is needed. Some infrastructure is required. It is not so easy to do it anywhere and everywhere. Some sort of infrastructure is required to maintain the stability. And we need some expertise, especially for infectious disease, especially for interpretation of results. Because we usually, even if minimal training and repeated training may be required in order to interpret these tests in emergency situations. Because if they are not laboratory trained personnel, if they are not working in the lab, if they are working in the point of care test, if they are doing point of care test in the emergency department, in the lab, and no skilled personnel are supervising them, then they may need repeated training in order to interpret, because we at the lab, even we as skilled professionals may require, sometimes we may have doubt in reading out the results sometimes. Even the rapid CAR test, we may sometimes have doubts. So, because sometimes faint lines will be there, then we have to go for clinical correlation, etc., etc. TrueNat, CBNat, that requires higher degree of correlation, higher degree of expertise. So when we are using that, it is always good to have someone skilled at least as a supervisor in the case of infectious disease in the point of care test, for at least for interpretation. Then quality assurance and regular compliance. Most of the point of care test has to undergo FDA and clearance in order to get the approval. That is a very stringent process. Only after that usually they allow this point of care test clearance, because after that the quality assurance is a question mark. Then cost and sustainability. Even though we say that it is costly, less costly, unlike in private setup, in government setup, we have to buy the machine. So it is not the running cost. We have to buy the machine also. So initial investment is costly, very costly, and then the running cost also comes. So it is actually a very costly procedure sometimes to maintain this. So even though the results are rapid, accurate, ease of use is there, everything, it is beneficial for the patient, everything is there, but it is initial investment will be there in the case of point of care testings. Now, some innovations already mentioned, so I'm just going through. There is a talk, I think, on advances in biotech in POCT, so I'm not going into detail of this. Already mentioned, lab in a chip. That's a microfluid. I just wanted to mention this. Microfluid means very less amount of fluid is taken. Femtoliter. Femtoliter means 10 raised to minus 16. Only that much amount of fluid is taken and you're putting it into a chip. Very small chip, everything automated. Everything is automated in that chip. And you're putting very small amount of fluid. And very small amount means large volume, the capillary force will not act. Here, very small amount of fluid in a small glass plates, 2 glass plates, within 2 glass plates, the fluid is flowing. The capillary and viscous force will act and it will travel through and the results comes, very fast results come. So lab on a chip. So that is a microfluidics. That is the technology that is being used in lot of analyzers now. So microfluidics, lab on a chip. It has been used for diseases like tuberculosis, malaria and COVID-19. Only thing is that it is expensive. In India it is available, this technology is available. Lot of companies are doing, Thermo Fisher, Biorad, lot of companies are doing this, kits based on this technology, lot of companies. Then another technology, I think the next speaker may speak on this, plasmonics. That is on the metal surface, the light comes and the electrons will come oscillate. Very small oscillations and the oscillations are lesser than the wavelength of light. Nanotechnology technology. This research is going on in India in the Jawaharlal Institute of Scientific Research at Bangalore. No, kits have not yet come, but these are all things that are undergoing advances in technology. Now future directions for POCT in infectious disease, AMR, antimicrobial surveillance. We have got kits for MRSA detection, for carbapenem resistance detection. We have lot of kits, lot of rapid CAR test kits like this we are available. So that can be used as a point of care test in order to find why this antibiotic is not being used in this patient, why it is not being effective in this patient. You can use it then and there, but clinical correlation, that is one thing. You should not treat the card or the report, you should treat the patient. So that is another thing. Then pandemic early warning systems. When we are using this card test, especially in the case of COVID or any other disease, when you're using it in the public health domain, when you're using it, it is very easy to use a card test for infectious disease. So when you're using it in the public health, it gives early warning. Early warning, so we can do early response, early global response, early maintenance, early the response, and it can help in effective management of the cases, effective containments. So that is very important in the case of pandemics. So that is one thing that can be used if you are effectively using the point of care test in the public health domain. So the summary, with its on-site application, reduced turnaround time, ease of use, cost effectiveness and better infection control measures, point of care in infectious disease and sepsis offers rapid diagnosis and better clinical outcomes. The only thing is that it should not be standalone. Point of care test is never standalone. It should be linked to action and it should be integrated into clinical decision pathways. It is not a standalone. The values are not standalone. Whatever results are not standalone, it should be linked to clinical. Clinical correlation and clinical linking is very, very important. Given the complexity of sepsis, a multi-biomarker approach is essential to enhance the diagnostic and prognosis precision. And it is not just a tool, it is a catalyst for change in diagnosis and management, particularly in critical care and public health. Okay. So a correct diagnosis is 3/4 the remedy. Thank you. Thank you for your patience.
Thank you, madam, for the wonderful presentation.
The session is open for discussion. Any questions? If there are no questions, thank you, Ardra, for the excellent talk enlightening us with the different types of POCTs, especially in terms of sepsis and infectious diseases, and the role of biomarkers and main advantages and disadvantages of PCT. Thank you.
Now I request Dr. Joanna Mary Magdalene to present the memento to Dr. Ardra R. Menon. I request Dr. Miriam Varki, former principal, TD Medical College, Alapura, Professor and HOD, Biochemistry, Pushpagiri Institute of Medical Sciences, to present memento to Dr. Joanna. Thank you, madam. Point of caring devices requires the use of biosensors. Biosensors offer rapid and accurate non-invasive solutions for diagnosis and monitoring. Our next session is about biosensors in diagnostics. I invite Dr. Bishore Ibrahim to share his knowledge on biosensors in diagnostics. Dr. Bishore Ibrahim is the Managing Director and CEO of View Biotechnology Systems Private Limited, a pioneering company in the field of medical diagnostics. With over 25 years of experience in the industry, Dr. Bishore combines deep scientific expertise with strategic entrepreneurial insight to drive innovation in diagnostic technologies. With a strong academic foundation in veterinary medicine, he brings a unique cross-disciplinary perspective, effectively bridging the worlds of veterinary and human diagnostics. His leadership has been instrumental in advancing accessible, high-quality healthcare solutions that meet the evolving needs of modern medicine. Biotechnology Systems has developed several point-of-care devices and kits for diagnosis of infectious diseases as well as hormonal and protein biomarkers. I invite Dr. Bishore Ibrahim to share his insight about biosensors in diagnostics. I request Dr. Anil Kumar P., Vice Principal and Principal in Charge, GMC Ernakulam, to chair the session. Dr. Anil Kumar is the Principal in Charge and Vice Principal. He is the HOD of Department of Anesthesiology, GMC Ernakulam. He has more than 30 years of experience in this field. He is an excellent guide and mentor for various student programs. I welcome you, sir.
Good afternoon, everybody. So now, this afternoon, we have a very important session, which is a non-invasive methods for at the point of care, and that is a very advanced technological innovations. To enlighten on this, we have Dr. Ibrahim. Please continue, sir.
Thank you, sir. Good afternoon, everyone. So, I wish to take some, wish to discuss with you something regarding the non-clinical part of POCT devices. Probably, I'll discuss something about the technologies, how the POCTs are made, what is the background of, whatever the technologies you have discussed here, the CAS test or the cardiac troponin T test, how these kits are made, what is the principle of measuring. So, this is what I want to discuss with you right now. So, like we have been discussing about POCT devices from morning, so you know what exactly the POCT is, where the measurement goes to the patient near patients or towards the patient. Yeah, so that's called POCT devices. And I consider that the most the important thing about the POCT is about decentralization of diagnostics. So rather than from the laboratories, the diagnosis can more. So the lab test can go near the patient or to the bedside of the patient or even to the home. So that is called a POCT. So it can be a rapid test or it can be a test which can prolong up to 1 or couple of hours. So but the point here is it is something like we are decentralizing the detection. Basically, whatever the POCTs we are discussing here is about detection technology. So whatever the devices, the POCT devices, what they are doing is they are converting a biological reaction to a measurable signal. That is called, that is what is happening in a biosensor or in a POCT device. So what I mean, all the POCT, other than a visual or a qualitative devices, we have to use a machine which measures the signal which is generated from a biological reaction. So that is called a sensor. So whether it is, the sensor can be a voltage, a current, like in glucose sensor, where the reaction produces a current which will be measuring into using an ammeter, that is the glucometer, or it can be an optical signal, whether the reaction can be like a color, it can be a line, it can be an image, or it can be a fluorescence, or it can be a light. So this is basically what we are sensing in almost all the POCT devices which you are interacting every day in your clinical life. I'll start right away with the liquid chemistry part, where we are very much aware about the chemistry analyzers, where we are using it routine in your laboratory, or maybe in your ER settings. You may have a small chemistry analyzer. So what we are doing in a chemistry analyzer is, say if you are testing glucose, we are using a conventional chemistry, where the production of color, when the reagents mix with the analyte, your glucose, that produces the color, and the color is measured using a colorimetric photodetector. So that is what is happening in a liquid chemistry reader. Similarly, a specific protein analyzer like a MISPA, which is very commonly used in the ER settings, where the reagents contains lattice particles or very specific particles which are coated with antibodies against the particular protein, and a coagulation or a turbidity produced inside the tubes are measured using a turbidometer or a nephrometer. So that is what is practically happening in POCT liquid chemistry readers. So in all these type of readers, we are using photosensing, where either we are measuring an absorbance, where a difference in the intensity of light is measured, or we are measuring the intensity of color, or we are measuring a turbidity, or what is the difference in turbidity which is happening in the chemistry readers. And this is a more POCT version of clinical chemistry, where whatever the liquid reagents are converted into dry reagents. So you can see a microfluidic cartridge. You might have seen in your lab settings, you have a small cartridge in which you add maybe 5 or 10 microliters of blood, and you insert it into the device. So this is like a centrifugal microfluidic device. It's a very commonly used nowadays in almost all laboratories or ER settings, where you can do a panel of testing rather than like the conventional chemistry, where you are testing individually one by one. In this type of cartridge, you can test, say for example, if you are measuring a lipid profile, or you are profiling kidney profile, you can do it together rather than doing individually, and within 10 to 15 minutes you'll get the results. So here the principle is basically it's a microfluidic cartridge, and when the disc rotates, the fluid moves towards the reagents, where the reagents are dried, lyophilized, and the reaction chemistry is almost similar to the liquid chemistry. Only thing is the difference is that the reagents are dry. So whatever the output of the reaction is, can be a color, or it can be a small difference in the turbidity, which is measured using a photodetector. That will be a photodiode. So when the disc rotates, at every point of reaction, the detector measures the color intensity and gives the results. So this is one of a very common POCT chemistry device. And urine chemistry, which is very, very commonly used in your clinical settings, where you measure about 11 parameters from urine pH to urine protein. So this is again a very, very simple strip-based photometric device, where again you can see that when you dip the urine strip in urine, that will produce a color. The color change in the strip, you can visually recognize the color change. So practically speaking, if you have a color chart, we can separate, we can classify the reaction based on the color chart. But to get a more accurate, more quantitative results, we can use the urine chemistry reader. Again, that is a reflectance meter, which will measure the difference in intensity of light using a simple photodiode. So that is urine chemistry analyzer, which is a very widely used POCT chemistry reader. Coming to the lateral flow POCT readers, probably this may be the most widely used POCT device in the world, I should say in the world, because of the simplicity and the ease of use on this particular. So this particular technology, like Dr. Adra said, the HIV test or the cardiac troponin test, whatever Dr. Mehdi said. So all these devices are using basically this principle. It is called immunochromatography. So the fundamentals of this card is a paper chromatography. So it contains a nitrocellulose membrane, a paper, in which we are printing the antibodies or antigens. So basically, it is like, if you know about ELISA technology, this is an extension of ELISA technology, where the antigens or antibodies are interacted and the reaction complex are measured using a measurable signal. So here the difference with ELISA is that it is or liquid or it's an enzyme in ELISA, but in chromatography or in the rapid card devices, what we are using is a particle. Most of the time it is colloidal gold. So the gold particle, which is of bright red color, that particle will be coated with antibodies, and when the particle binds to a particular antigen, the antigen antibody binding will precipitate the lines on particular lines, on the particular sheets. So the beauty of this technology is that it is very easy to manufacture. It is unlike, it can be manufactured in millions. So the technology is so advanced that, in a day, we can, when you may be knowing that during the COVID time, the scaling up of the device were so huge that we were manufacturing it in millions. So this test can be a qualitative or it can be quantitative, like the one which you are using, commonly used in your setting, maybe the HIV test or the malaria test, where you can see the signals visually. These are qualitative tests, whether it will say that it is yes or no, whether the test is positive or negative. But this can be a quantitative test, where if you use a reader, if you can use a point of care device, a reader, or in the newer development part, we can see even you can use a mobile phone to quantify your thing. So what we are doing in that quantification is we measure the intensity of lines. Say for example, there is a test line and a control line. So we can measure the intensity of the test line, and that you can correlate with the standard curve. So that can give you a quantitative result. Like some of the troponin eye test, which is in the market, is in this platform. And here, in the quantitative test, the image processing it can be a simple photodiode based sensing, or it can be a camera. A camera can capture the image. It can further process the signals using image processing algorithms. So this is an extension of the previous technology, the lateral flow, the fluorescent POCT. And I think this, most of the POCTs, quantitative POCTs available in your clinical practice must be this technology. But the technology is basically immunochromatography or the lateral flow. But the difference here is we are using a fluorescent particle here. Instead of the gold particle, we are using a lanthanate. That means europium. It's the beauty of europium is it is excited at a very low wavelength, that is at 360 nanometer of UV, and it emits wavelength at red range. So your differentiation range, there is no mixing up of wavelength in this. So this particular technology is 50 times more accurate, more sensitive than the conventional rapid or the lateral flow technology. And a reader, a POCT reader, which measures the red light emitted from this particular line is, we can quantitate. So, I mean, like ma'am said, you have to have a chip. Why you need a chip here is that the calibration data for every test, say for example, if you are using cardiac troponin T test in your laboratory, that need a calibration. So the calibration data from every manufacturer is fed in that particular chip. The chip contains a standard curve, which will be pre-calibrated in the manufacturer setup, where they will be measuring, they will be creating a normal standard curve. And whenever you get a patient reading from your machine, what the machine is doing is that, what the software is doing is that that particular value will be fitting into that curve. So that is why the chip is very important. Sometimes instead of chip, we can use QR code. Some of the kits may be contain the QR code instead of a chip. So most of these type of devices use a CMOS camera to interpret analyze the result. So this is that's the way of sensing in these devices. So the chemiluminescence assay. So CLIA is very common in our laboratory settings, but nowadays CLIA became very user friendly. CLIA became a POCT where you can earlier we used to have say 10 samples or 15 samples to run a CLIA, but now POCT CLIAs are available where you can run a CLIA test on individual samples. You can have a cartridge like this where all the reagents are pre-filled, dried in it, and this uses a technology based on magnetic beads where the antibodies or particular analyte is bound to an antibody, and that can be separated very easily using a magnet. And the detection can be the detection will be a very high sensitive sensor where the chemiluminescence is produced from the reaction. Usually, you know that in chemiluminescence we use substrate like luminol or acridine ester, which will produce light whenever it will be triggered with a chemical reagent. So that light can be measured using a small sensor. The real-time PCR. So probably this is going to be a very, already the products are in the market. There are large number of products, whether it is based on the Tachman chemistry or based on the isothermal amplification. So the real-time PCR can be based on the Tachman chemistry like the Cepheid platform where the GeneXpert is working on that particular platform, or the Molbio TrueNat is working on the Tachman platform. And that capability of the Tachman is that there is a very high possibility for multiplexing. You can do, say, there are like the BioFire array system where you can multiplex more than 20 parameters in that. So similarly, in the isothermal system, the difference is that the amplification happens, the DNA amplification happens in a single temperature, in a single incubation. So the technology is very simple, but the detection technologies can be similar to Tachman, where you can use a Tachman probe or you can use similar dyes. So what is happening in real-time PCR is that we are using specifically selected dyes like FAM, HEX or Sci-Fi or ROX. These dyes are excited at a particular wavelength and they will emit wavelength of, light of different wavelength, which can be measured using a small photodiode or a camera. So that is happening in the PCR machine. So this is a very, very common, probably in most of the microbiology or clinical microbiology settings, we can see these POCT machines based on both the technologies, isothermal amplification or from the real-time PCR. Electrochemistry, which probably may be the most widely used, one of the most widely used POCT devices, which you are aware about, like our glucose sensor, where we are measuring, we are converting the biological reaction to current. So for example, in glucose, the enzyme, see, the beauty again with this particular technology is that the manufacturing is very simple. So the electrodes which you are seeing, the strip in which you put blood, that is actually manufactured using a very simple technology called screen printing, where you may be knowing the normal screen printing where you print notice. So the same technology is used for manufacturing the electrodes. Instead of normal ink, we are using carbon or silver inks, where these are conductive, which can conduct electricity. So we can print that ink on a plastic backing, and that can be used for, that is used in these devices. So again, this sensor technology is of two methods, where you can see some of the devices like AccuSure, which measure the current which produced due to the enzyme reaction. This can be of glucose, can be of lactase, or you can use wherever an enzyme reaction is possible. If you have an enzyme which can oxidize your particular analyte, we can use this sensor. But the platform like AccuCheck, we are using photometry. So you can see that when you put blood in AccuCheck, there's a small slot where they will blink an LED, and that will detect the reflectance of measurement, unlike the other method where we are measuring current. So this is the future, wearable biosensors, which is already in the market. We can see that the glucose about, that freestyle, it is already in the market with continuous glucose monitoring. Similar wearable biosensors are already on the way for measuring other parameters, probably for cholesterol screening. It is already in the pipeline. And smartphone integrated POCT devices, which can make, which can eliminate a capital investment of having a POCT machine, where your signals can be captured using your smartphone camera and can be further analyzed using a cloud-based analysis. And home POCT sensors, of course, that is coming up, which is even for screening cancer markers like C-reactive, like PSA or CEA. So this type of cancer markers, the companies are planning to launch home-based screening tests, which can make, in which people can, those who are susceptible for those conditions can go for a continuous screening. And of course, AI and machine learning, which can, this is more of a digital pathology, where nowadays very fast automated scanning systems are coming up with fast scanning and automated analysis of slides. So this is already in the market. So that's about the basics of diagnostics. This is how the kits are made or the devices are made. Thank you.
Thank you, Dr. Bishor Ibrahim. Now the session is open for discussion and any questions are welcome.
Sir, I've heard about you long ago. You buy on as, I think, the neighborhood company. You got there's a sets over here nearby. I think you are you the one who run, what do you call that, run that company? I think, I think in the neighborhood only. So I've seen you. I know that you tried to settle in America and started a company over here in Kerala itself. Yeah. Thank you, sir. It's nice meeting you again. What about the chikungunya kit? Is it still being manufactured, or you still manufacture chikungunya?
So many of the technologies which we currently manufacture are licensed from a lot of institutes. I used to, medical college also used to support us in a lot of product development. So during our initial time. So this is a we are a pretty big manufacturing facility, which is, we can actually see how the manufacturing happens of all these POCT devices.
there are no further questions, we will close the session. Thank you, Dr. Bishop.
Thank you, Dr. Vishor. Ibrahim, Biosystems are just opposite, the company is just opposite to the gate of GMC Ernakulam, and Dr. Vishor is very supportive in research and all the materials there. I request Dr. Anil Kumar P to present a memento to Dr. Vishor. Next, I request Dr. Lakshmi GS, Professor and HOD, Sri Erakulam Institute of Medical Sciences and Foundation, Thiruvananthapuram. Lakshmi Madam came all the way from Trivandrum to present a memento to Dr. Anil Kumar. Thank you, Madam. Thank you, sir.